CBME conference. So I request Dr. Lograj sir to start the today's activity.
So very good morning, all participants. So we welcome you all for the second day of the plenary sessions. I hope this today all the plenary session will be helpful to you. And to start with Dr. Amol Dongre, followed by Dr. Nachiket Shankar, then Dr. Sunita Vaga, then Dr. Saya Prakash Sarasan, followed by Dr. N. Sita Raman, and the last speaker will be Dr. Kavita Rati. So I hope uh, all these sessions are very important in the implementation of competency-based medical education. At the end, we will have a validation session, and we will announce the prize for the poster, oral, and short film competition. So over to Dr. Balaji. Please take over.
Thank you, sir. Yes, we had a good scientific session yesterday, and followed by that we had poster and oral competition. And this morning we also had a short film competition and the remaining poster and oral competition. It was indeed a great participation by most of you, and the presentation really good. And thanks for making this conference really successful. With this, I'll take you to the scientific session for the day. So we have an eminent speaker to start for the day. Most of you would have listened to his speech as postgraduates or in medical education, in community medicine, everywhere. And it's a pleasure to invite Dr. Amal Dongre sir for our conference. I will share his credentials. Dr. Amal Dongre, sir. Yeah, I think it's visible now. Dr. Aman Dogresa is presently working as a professor and head in the Department of Community Medicine and Dean Research at Sri Manakula Vinayaga Medical College and Hospital in Pondicherry. As international fellowship in medical education, he has completed Masters in Health Professions Education from the Kiel University in UK. His working has FAMER regional faculty in two regional centers, PSG Coimbatore and Manipal University. And he'll be presenting the title. The title of his presentation is Strength, Weakness, and Areas for Improvement in the Postgraduate Assessment in Community Medicine at Delphi State. Thank you, sir. It's over to you. I will stop
Very
sharing.
much for your kind introduction, and thanks to conference organizers for giving me the opportunity. Can you hear me clearly? Am I audible?
Yes, sir. Yes, sir. We can hear you.
Uh, what I'm going to present in my today's session about strengths, weaknesses, and suggestions for improvement in postgraduate assessment in community medicine in India. It's a Delphi study, and this was my thesis topic when I did my master's in health profession education. And when Dr. Lograj invited me to this conference, I proposed this topic to him, and he kindly agreed to have this topic in this conference. And I'm going to share what we did in this study, and then we are going to draw some lessons learned from it and what we need to do in improving the postgraduate uh, assessment in the future. Now, let me put some background here before I proceed, that why we did this study and why this was chosen as a topic for research. The first point is that over the years, postgraduates in community medicine have been assessed using traditional assessment framework. That means we have practical exam and we have theory exam, and then we have to clear those things to get our final certification to practice. And this is going on right from its inception. And the another feature of our assessment system is that decision about final certification is based on just one university exam, And that is true even for undergraduate, and that's true for other subjects as well when students go for post graduation. The third point that we have to keep in mind is that this assessment framework of having just one university exam is less defensible because it uses less methods, and it is primarily focused on knowledge assessment. However, we understand in a developing country like India, this seems to be the most practical and feasible model. But with rapid change in education in rest of the world, India too have to upscale their standards in education and particularly in assessment to meet up those requirements for our assessment system. So in India also, if you say right from since last two decades, we are having discussion that we need to change our education, we need to improve our assessment. But even though we have discussion on this topic, there is very limited discussion on building a consensus about what to change and how to go about the change, because making change should be an incremental process. And if you make a radical change, then it becomes really difficult for teachers, students, parents to accommodate all those changes if they are done very rapidly. But if they are incremental, then they are easy to do, and then they are likely to be more sustainable in the future. Now, having said all these points, it creates a background that we need to study something about for the consensus building in improving the assessment in community medicine. But we decided to have first objective as to understand the strengths and weaknesses of overall current assessment system in community medicine. So we thought that there are some strengths and there are some weaknesses also. And my guide, Professor John Narsini, who was guiding this thesis, he said that no, we should also explore some of the strengths of that assessment system because it is lasting for long time. So we should try to take out some lessons from that system, which is so stable for so long. And then what are the weaknesses and what are the areas for improvement? And then finally, after exploring that, then we should go for exploring some finding out some opportunities for improvement and then build a consensus on mm, recommendations for improvement. Now if this is the objective, then naturally we would require some kind of exploration and some kind of consensus building on that explored items. So keeping these two objectives in mind, we developed the material and method section, and this consisted of research design and assumptions, because whatever research we do, we have to have an assumptions. And since this was a kind of a educational research of qualitative in nature, the exploring explaining all these terms becomes very crucial. So we used a qualitative design which has a constructivist paradigm. Means initially we wanted to explore the things and then later on develop the questionnaire for consensus building on that. So going to be a kind of an iterative design for building a consensus on that. So we decided to use a conventional Delphi technique, and we know that Delphi technique is very popular for building consensus among experts, and it is named after goddess Delphi, which is known for predicting future. And basically it was used by American army to select cities for nuclear bombing in Japan. And later on it got popular in educational research and other social science research, particularly where you need to build a consensus with geographically scattered experts. So we thought this design is very appropriate for the objectives that we have chosen. But we had an assumption for this design is that that group opinion is more valid than the individual opinion. And so then some of you would question that how can we trust the group? So that's an assumption for Delphi technique and for nominal group technique. Then we had a question of thinking about sample size and sampling. And we reviewed the literature and we found that the sample size of 10 to 15 experts for this topic would be sufficient because past research has shown that you tend to get more stable results with that sample size. But we decided to have little higher sample size than that so that if there is any loss to follow, then we still fall in the range of 10 to 15. And this we decided to have 18 experts, and we invited 18 people and 16 of them gave full responses for all the three phases of this study. Being a qualitative study, we had to go for a kind of a purposive sampling. And in that purposive sampling, we thought that a criterion type of purposive sampling would be more appropriate. In criterion type of purposive sampling, we try to select participant which meets our specific criteria. And so we had some criteria such as those experts or those faculty in community medicine who are experienced in teaching postgraduates, and those who are part of postgraduate assessment, those who had training in the field of medical education were considered as experts. So that was our operational definition of experts. So they were invited to participate. And we did a kind of a brainstorming to select those experts on the panel. This proposal was presented in front of the key FEMAR and SENMEDIC experts in UK. And after they approved it, after its approval by the university and the course facilitators, this proposal was presented in Institutional Ethics Committee and we got an IEC clearance. And after that IEC clearance, we started collecting data for it. So now let us see how we collected data for it. So we used a Delphi rounds, and typically you need 3 to 4 rounds of an iterative nature to build a consensus. So we did 3 rounds to build a consensus. In the first round, we emailed some broad open-ended question to all these 18 experts with the purpose of exploring the strengths, weaknesses, and suggestions for improvement in the assessment. So they were broad open-ended question and they were emailed to all these experts. So before mailing them, we obtained their consent, and once they agreed, we emailed it to them. And we gave them a small SMS reminder that we have emailed this stuff, these questions to you. Please respond them at the earliest. And I'll be showing you what happened after that. So this was a Delphi round 1. And so they were expected to write down their text response to these questions. And once they write it down, they were asked to submit it as a Word file to the email ID of primary investigator. Then after receiving all the responses from the Delphi round 1, we planned Delphi round 2 and 3. So in Delphi round 2, we got responses from all 16 experts. 2 of them did not respond even after 2 reminders. So we decided to go ahead with those 16 experts who completed the round 1. And based on what was said in round 1, we did a content analysis of it and developed a Likert type of questionnaire and emailed it back to the respondent. We also emailed them the summary of content analysis that we had so that they get a controlled feedback of that thing. And so this questionnaire was thus based on the findings obtained in the round 1 of Delphi study. The Purpose of second round of Delphi was to build a consensus that, okay, you said those points and these are the 14 points. We think we can go ahead for building a consensus, and tell us which one is more important and we should be focusing more on making a change in postgraduate assessment. And after Delphi round 2 was over, we did some kind of a consensus analysis and found that some items are salient. And in Delphi round 3, we asked the experts that, okay, thank you for your nice responses. We got consensus on some of the items, but they are quite a, they are large in number. And so we want to make an incremental change. So in order to do that, we would like you to select the top 5 items that you would like to see making a change in immediate future. And for that, we selected only those items which reached a consensus of more than 90%. And that we took for round 3 of the study. So this is how we used a kind of a funnel approach, right? We started from very broad and then we tailored it down to some specific items for consensus building. Now, how we did the data analysis, as I mentioned already, that Delphi round 1 consisted of manual content analysis, that we took out the printout of all those responses, and then I had to go through them and then do a content analysis of it. And my colleague helped me in that process. And my guide verified what all we have done. This brings a kind of a trustworthiness in the findings. And this triangulation of researchers brings an element of validity in the measurement. So then we developed a questionnaire. We all three reviewed it, and then it was mailed back to the participant. In Delphi round 2 and 3, we used a consensus measure, which is a new measure being used for analysis of a Likert type questionnaire. When you ask a question on 5-point Likert scale, from strongly agree to strongly disagree, then this type of measures really help us to do the interpretation, because this gives us a mean value on that scale, and then how much is the consensus for that mean value. That makes interpretations very easy because you get only 2 figures which you can see and make an interpretation about the agreement. For our study, uh, we use this range, the consensus values. 0 means there is no consensus, and 100% means there's a full consensus, of course. So a value which is above more than 80% was considered as good consensus in round 2, and then those who values below 80% were considered to have poor consensus. This was an arbitrary cutoff that we chose based on the data that we found, and we found that most of the experts tend to agree to most of the items. So we had to be really ambitious in setting the standard high, and we decided to have 80% as a consensus agreement for the consensus. So this is what the status of Delphi round 1, 2, and 3. So this is the picture. At round 1, we got 18 participants, and then round 2 and 3, we got 16. And number of response to request, no response to the request, 2 of them dropped in the first round, and 16 of them completed all 3 rounds. And this study was done almost in a month time, so it took nearly 4 weeks for me to complete all the rounds. And 2 of the experts requested for little extra time due to their busy schedule, so the timeline was a little extended for them. And so who were those experts and what were their background characteristics? So there were 9 male and 7 female. 8 were from the government college, 6 were from private, and 2 were from the semi-government. 14 of them were affiliated to the government university, and 2 of them were from deemed university. And they were from diverse background, such as from being associate to additional to professor and head to dean medical education to consultant to the university. So they had a diverse background, and diversity really helps um, in getting the variety and then building a consensus later, particularly for getting a variety. And most of them had a very high qualification, that they had master's degree, they had fellowships, and they had done courses with MCI and FEMA and from National Teachers Training Center, JIPA, Puducherry. So they had a very strong background in their profession and in medical education. So when we ask these experts, what are the strengths of our current postgraduate assessment system? Um, and they actually said a lot of points, but I just brought 4 points here for you to comprehend what happened. Actually, it was a very large data that we got. The expert felt that the strength of our current postgraduate assessment system, that it strengthens the students' cognitive domain. They felt that it is suitable to our context, particularly considering the resources of our country. Some of them felt that it is authentic because we give them clinical social case in community setting. And so that makes this assessment an authentic one. And finally, they say that it is traditional and it is time tested. Over a long period of time, we have been running it. So we have acquired wisdom in running it. So let's retain that wisdom when we go for further. When we ask the experts that what are the weaknesses of our assessment system, current postgraduate assessment system in community medicine, so they said that it is too much focused on cognitive domain. There is no formative assessment. There's no provision for it. However, some of them said that there is some kind, because the practices varies from college to college, but majority of them felt that we don't have any kind of formative assessment. Formative assessment is a kind of an assessment which we carry on throughout the course, with the purpose of giving feedback to the student so that student keep on meeting those competencies and don't get any disappointment when he or she faces the university exam. Experts felt that we have a poor use of methods, we have poorly trained examiners, we are more subjective in our assessment system is not fair, and some of them felt that actually the assessment is good, but there is a problem in its implementation. And they said that it's doing fine, but we need to improve the teachers, we need to improve the majors, and we need to bring some kind of objectivity into it. So this is what we got from them. We did a content analysis of all the text information, and then we developed a 14 item Likert type of scale and emailed it to participant once again in Delphi round 2 with some controlled feedback on the analysis that we obtained. And then we got this output that uh, that they said that, and then we did a kind of analysis on that. I mean, I'm not showing the statistics of consensus score here, but then in that we got some items with more than 90% of 90% of a consensus measure. And so we asked them that we are giving you some items, so please rank order those items and select the first 5 items. And then we entered that in a software called Anthropac, and we asked the software, tell us which are the most salient items in the list given by these experts, because they now know what are the salient items. And among them, they were asked to select their top 5. And so they selected it. And they said that the first point, all of them agreed, is that assessment in community medicine should be based on desired competencies, what postgraduates are supposed to do in real world, the assessment should be focused around that. The experts also agreed, the point number two was that they also agreed that there should be a system of formative assessment. The experts agreed that the opportunities of posting the postgraduates to rural health center, urban health center should be used for formative assessment, particularly using multi-source feedback and by using tools such as workplace-based assessment. Of course, to do that, we need some kind of steps to be taken, but that's really a golden opportunity for us to assess our student at workplace and give them feedback. The third point which came forward is that okay, we already have a postgraduate logbook, so why not we provide some space for reflection in that, because reflection improves the learning, because when learner look at the thing from a reflection point of view, the learning improves. However, there is a very poor culture in our country about not having reflection anywhere else, not in undergraduates or post graduation. And that's really a missed opportunity. And we can use logbook not just as a diary of your activities that you have done, but what is your reflection on that? What is your learning when you have gone through it? Then another point that experts agreed that we should have structured guidelines on occasion, frequency, and competency to be assessed. I mean, what occasions, how many times, and which competency we will be assessing. So that requires a very good framework to be developed for that. Experts agreed that there should be an alignment between what we assess and what is expected. And that match between expected and assessed can be very well breached by having a blueprint. So another point experts agreed that this blueprint should be communicated to the examiner. Now, theory questions should be based on high order thinking and problems, and examiner should and we need structured format guidelines for feedback. The another thing on which we could not achieve consensus was standards for external exam, because one of the quality parameter for any examination is that we have to have an examiner with some minimum standard. So we have two ways of doing it, either to have an external examiner or to have external examination. We look forward that that change will happen in our country in some way, because having external examiner is a British practice and having external examination is an American practice, and both are getting streamlined in our country slowly. Finally, we tried to develop a model, and this is what the our experts suggested, that we should have formative assessment, development of ongoing assessment, feedback. So assessment should be based on desired competencies, there should be blueprint, there should be improvement in use of current assessment measures rather than trying something new. We can improve on what we have in our hand. Then we should develop some guidelines and checklist for objective assessment, training of faculty in use of assessment measure. And then one more suggestion that they give is that there should be exit interview with all students completing the assessment, and then that feedback should be given to those who develop the assessment system, so that we keep on making incremental improvement in our system. We have a long way to go on that, but to begin with, we can bring some good practices of improving our own assessment practices, such as using assessment measures judiciously. So the strengths and limitation, that this was the first systematic effort. That's what we feel based on our knowledge. And but the limitation should be kept in mind that myself and my guide, we had a background in education. We were studying in that field. Particularly, I was studying in that field. So our background might have influenced the way we have conceived the study, frame the objectives, and ask the questions. So that you have to keep in mind. And finally, that the participants' background also might have influenced the way they have said on those points. But we believe that those experts are well versed with our context and would give us more honest responses, which is feasible for our context and for our resources and for our capacity. So it is noteworthy that most of the consensus items were in alignment with the modern assessment theory. So this should be considered by the accrediting agencies, regulating bodies, and policymakers for improving postgraduate assessment. And when we did a literature review, we found that these practices are more or less similar in other subjects in India, even in Southeast Asia region. So we can take a risk of saying that these findings are transferable to other subjects and other contexts, and they can also think of making the similar incremental improvement in their postgraduate assessment. So just a sort of an acknowledgement here. I have already disclosed that this work was done as a part of master's thesis from the King's University under the guidance of Professor John Larsini. So I acknowledge and thank him. We thank all the Delphi experts for giving us their valuable time and inputs to improve the study. And we thank Dr. Lograj for kindly accepting to have this topic in this conference. And I thank all the MEU unit members and organizations of this online national conference on challenges in challenges in implementation of competency-based medical education. So thank you very much for your opportunity. I'll be happy to receive your comment question. So thank you very much.
You have. Thank you, sir. Thank you for doing a very nice presentation and sharing your experience with such an extensive study with a robust methodology of Delphi technique on the postgraduate medical assessment. And also, you are sharing a model framework that came out of the study. It was really a nice experience to listen to your talk, sir. And I don't know
I saw
any
one
question.
question.
Yes, sir.
The participant has asked a question about how to assess the reflective writing. And that's really a good question. That's a big challenge. And I have one rubric developed, but that's not developed in India. We have done one small study in India that in order to develop, in order to assess the reflective writing, if you can drop your email, I will send you some link and that will tell you some guidance about it, how to assess the rubric. Uh, we have a rubric for assessment of reflective writing. We can develop rubrics based on what you want for your study, for your
Sure, sir. So we would like to give a certificate for your participation as a speaker in this, sir. So kindly accept it.
Thank you very much. Really nice.
Yes, sir.
Thank you.
Thank you, sir. Thanks. So with this, we'll move on to the next session. Okay, I'll be sharing.
We learned a lot of things.
Yeah. Yes. For the next session, we have Dr. Nachiket Shankar. Uh, Sir is a member MEU Medical Education Unit in the St. John's Medical College Medical Education Unit. He's an associate professor from the Department of Anatomy. So the topic he's going to present today is alignment, integration, and learning in competency-based medical education. Over to you, Asad. Nice to have you in the conference.
So, thank you very much. Are you able to hear me?
Yes, sir.
Okay.
We are able to.
So, I will share my slides and you can please confirm that you're able to see the slides.
Definitely, sir. Please share. Yes. You can put it on slideshow. It's visible. Yes.
Visible, sir?
Yes.
May
Yes,
I
sir.
start,
You
sir?
can.
May I start?
Yes, sir. You can start.
Okay. Thank you so much. First of all, I'd like to thank the organizers for giving me the opportunity to speak during this conference. It is indeed a pleasure and privilege for me to do so. And after the wonderful presentation by Dr. Amol, we move on now to the next presentation. And my presentation is titled Alignment, Integration and Learning in CBME. Now, before I start this presentation, I understand that there is a varied audience, some of whom don't have much experience in medical education. On the other hand, there are experts in medical education as well. So my talk probably will resonate more with those who don't have that much experience with medical education and might be a bit of a repetition for those who are experts. So with that brief introduction, let's move on to this slide and think about how this relates to integration. I think this is a very well-known example of the blind men and the elephant. So they're asked to feel the various parts of the elephant and say what it is. So one person feels the tail and says it's a rope. The other person feels the flank and says it's a wall. The other person feels the ear and says it's a fan, and so on and so forth. So till now, our medical education was something like this. If you take the elephant as, let's say, a common disease that is there in the population, let's say tuberculosis, we were studying tuberculosis piecemeal, right? So we were studying something, let's say, about the diagnosis of tuberculosis in microbiology, the anatomy of the lung in anatomy. We were studying the clinical features when we saw a patient with tuberculosis in the ward, but we were not actually connecting everything together and looking at it in a holistic manner. So the attempt of integration is to make sure that we see the big picture and we see the elephant as a whole and not as individual parts. So what we are going to explore during this session is that we're going to look at three important questions in relation to integration. First of all, why we need integration, which we've already touched upon. Second, what is integration? And third, how do we ensure that integration is achieved in a curriculum? So these are the three aspects that we're going to look at during this session. And we are going to focus on the how, specifically in India, how we plan to introduce integration into the curriculum. So let's start off with the first question of why integration is needed. Right? So let's begin at the end. The end product of MBBS training, all of us are familiar with, is to produce a competent Indian medical graduate who is a skilled and motivated basic doctor. Now, in order for this doctor to be skilled, it should not be that his mind is filled with isolated bits of information which cannot be connected when confronted with a practical situation, right? So there is the existing medical education system sort of is something like this, where theoretically the student is excellent and has multiple bits of information, but is not able to connect those bits of information in the practical and clinical context. So that is the whole purpose of integration. And the formal definition or the rationale behind integration is that it is easier to use and retrieve information, retrieve and use information when it is combined in meaningful ways. So that should be our effort, right? To ensure that this is what happens in the mind of the students, that they are able to retrieve and use information and when it is combined in meaningful ways. So this is a little bit of the neurophysiological basis of integration. The two areas that are supposed to be important for integration to occur are the hippocampus and the medial prefrontal cortex. And there are oscillations that enable transfer of information between these two areas. So just to give you an example, let us say that there is an association between the apple and the picnic basket and the guitar and the picnic basket. Automatically, because of the connections between these two areas, the guitar will be connected with the apple, right? So you can connect things that are independently connected to other things. And basically neurons that fire together, wire together. So when our students, you want all their neurons to fire together, when, let us say, they are confronted with a practical situation. So this is a little bit about the neurophysiological basis of integration. So I would like all of you to reflect for half a minute or so and think of situations either in your clinical practice or involving interns where a lack of integrated learning has impacted patient care. Okay, so I'm sure you have examples of that. So we've probably looked at and made a compelling case for integration in the curriculum. Now let us look at the next question as to what is integration. This is pretty simple. Hardin has defined it as follows. It is the organization of teaching matter to interrelate or unify subjects frequently taught in separate academic courses or departments, right? So I'm going to use examples from anatomy, physiology, and biochemistry because that is what I am comfortable and familiar with. So let's say that we have the dissection of the thorax and the cardiac cycle in physiology and cardiac enzymes in biochemistry. There is an attempt to unify all these three rather than teach them as discrete aspects of the curriculum. So it's very simple to understand. This is what integration is. And the types of integration are basically two types, again very simple. Horizontal integration, that is in a particular phase, let's say anatomy, physiology, and biochemistry, like the example I just gave you, there is an attempt to integrate those concepts. That is horizontal integration, that is within a particular phase, subjects that are taught concurrently. Whereas vertical integration relates to subjects that are taught in different phases. For example, anatomy, pathology, and surgery, right? So this is an example of vertical integration. And there are many ways of doing this, and three ways I will just mention. So one is by way of topic. For example, let us say we take tuberculosis as a topic. We could use that topic as a framework for integration. We could use organ systems or themes, for example, cardiovascular system, in order to achieve this integration. Or we could have cases where we have clinical case scenarios as the core for integration. So this in brief are the types of integration, horizontal and vertical. And from the GMER document, this is what has been mentioned. The triangle on the left relates to the basic sciences and the inverted triangle on the right, the clinical sciences. And in the first year, 20% of the curriculum and curricular time is supposed to be spent on bringing in the relevance of the clinical sciences in learning the basic sciences. That proportion increases to 40% in the paraclinical subjects. And finally, in the clinical years, that is phase 3, 20% of the time is spent on looking at the relevance of the basic sciences in clinical practice. So it's the inverted pyramid. So 80-20, 60-40, and 20-80. So this is the proposal in the GMER. Please note that in no place is there zero, right? So for example, when you go to the final year, you don't completely forget about the preclinical subjects. Similarly, in the first year, you don't forget completely about the clinical aspects. So there is always some component of the other subjects that are included in the integration. Now we'll come to the main part of the session, that is the how of integration. And before that, I'd like all of you to just think for half a minute of integrated sessions that you have conducted or participated in. Okay, so we'll try and use this ladder called the integration ladder of Hardin to see how integration can occur. Now this ladder appears very complex. It is a little complex, and at the bottom rung of this ladder is isolation. Okay? Isolation means that there's absolutely no integration. And at the top of this ladder is the transdisciplinary. right? Integration. So there's absolutely no boundaries between the different subjects. So this is, you can say, the ultimate level of integration. And what we are trying to do in India in CBME is to look at the middle 4 rungs of the ladder. So I'll be spending a little more time on these 4 steps. That is nesting, temporal coordination, sharing, and correlation. However, I will be making a passing mention of the other steps as well. So let's start off at the beginning, that is isolation. Each of these squares represents a department, and let's say this is anatomy, physiology, biochemistry, and let's say that this is community medicine in the first year. They organize their teaching in separate compartments, and there is no consideration. For example, anatomy does not even know what physiology is doing at a particular time point. Physiology doesn't know what biochemistry is doing. So everyone prepares their timetable independent of the other department, right? So this was the case in most medical colleges till CBME was introduced, right? We were working in complete isolation. So this is the lowest rung where there's absolutely no integration. The next step is awareness. And this dotted arrow, at least we attempt to know what is being done in another subject. For example, there is at least a sharing of timetables between anatomy, physiology, and biochemistry. So I at least know what is being done in another subject. So in this way, I can avoid some redundancies. Okay, so this is the next step, that is awareness. The third one is harmonization. Here, we actually take an active interest in what another department is doing. Let's say that this is anatomy and this is physiology. Let us say that I know that the physiology has completed the cardiac cycle. So when I do dissection, or when anatomy does dissection of the thorax, I try and build on the knowledge that the students already have from their physiology class, right? So here there is an active attempt on the teacher to incorporate elements that have been taught in other subjects, right? So this is called harmonization. The next one is nesting, and this is what has been proposed in the new GMER as one of the methods of integration. Let's say that this is anatomy, this square is anatomy, and let's say that this is surgery. Let's say that when I'm taking a class on the anatomy of the inguinal canal, I relate it to direct and indirect inguinal hernia, right? So I'm not bringing in a surgery expert. I myself am talking about the clinical relevance of inguinal hernia when I'm talking about the anatomy of the inguinal canal. This can also occur in the clinical subjects. Let's say that this square is surgery. When the surgeon is demonstrating to the students, let's say a patient with inguinal hernia, they may talk about the anatomy of the inguinal canal, right? So this is called nesting, and we have already been doing it, I'm sure, all of us. But now there is a conscious effort to make it a formal part of the curriculum. Okay, so this is called nesting. So previously, all the 4 methods were at an individual level. From here onwards, the departments need to come together in order to be able to perform these steps. So the next step is temporal coordination. So imagine that this is anatomy, physiology, biochemistry, and community medicine. So there is an attempt to cover similar topics at similar times. The same example I'm going to give. So anatomy is doing dissection of the thorax. Physiology is looking at cardiac cycle. Biochemistry is looking at, let us say, enzymes. And let's say that in community medicine, they look at the community incidence of myocardial infarction or something related to that. So there is an attempt to look at topics that are done, similar topics at the same time. And we hope that if they do that, integration will occur in the minds of the student, because that's the most important thing. So this is called temporal coordination. In CBME jargon in India, it's called alignment. This is what we mean by alignment. The next step is sharing, and I think this we are all familiar with. For example, if I do a class, let's say I finish the dissection, or we have finished the dissection of the thorax, we call a cardiologist to give a guest lecture about stents, or about a cardiothoracic surgeon about bypass surgeries, right? So we share some of the teaching sessions, or some departments have shared lectures as well. Let us say that we are looking at muscle. One teacher talks about anatomy of the muscle and classification of skeletal muscle. Physiology talks about how muscle contracts, and biochemistry talks about the various, let's say, enzymes that are there, right? So that would be an example of sharing. Different departments actually come together and share a session. The last step, as far as the Indian context is concerned, is correlation. And this is the so-called linker session that is talked about. Still, there are very clear the departments work as departments as far in subjects, in isolated subjects like anatomy, physiology, biochemistry. But there is an attempt at times to bridge those departmental boundaries. For example, a linker session could be a clinical case scenario. Let's say that we have a patient with myocardial infarction, and around that myocardial infarction, we discuss anatomical principles, physiology principles, and biochemistry principles. So this is, you introduce a case, it's a slightly higher level, but still that's only a small part of the curriculum, right? The curriculum is still largely discipline based, that is in subject based. And this is the last step that is supposed to be done for CBME in India. Now we move on to the other steps. The complementary level is that most of the curriculum, you can see that these squares are becoming smaller. So the distinction between departments is becoming smaller and smaller, and most of the curriculum is integrated. You can see that most of the curriculum is integrated. It is similar to the previous step, except on a larger scale. Steps 9, 10, and 11, I've clubbed them together because they're not that relevant in the Indian context, as the transdisciplinary would be a complete, there'll be complete dissolving of the boundaries between the subjects. So it's just the whole body of knowledge. An example is a problem-based learning curriculum, right? So in a problem-based learning curriculum, the subjects per se are not important. It's the whole body of knowledge that's used. And in between that, you have multidisciplinary and interdisciplinary. We will not go into the details. So some universities have their content organized into systems, cardiovascular system, respiratory system, and not as subjects. So multidisciplinary and interdisciplinary would deal with something like that. So if we come back and summarize the integration ladder of Hardin, isolation means there's absolutely no integration. Awareness, harmonization, and nesting occurs at an individual level. Temporal coordination, sharing, and correlation require the crosstalk between different departments, but departments still are very much in existence. And as we go higher up, the departmental boundaries blur, and we, at the transdisciplinary level, it's the whole body of knowledge that matters. Okay, so let's now, after having looked at Hardin's ladder, let's see how it applies to CBME in India. The current scenario till last year was something like this. So each of these rows represents one subject. Anatomy was doing dissection of thorax here. Physiology was doing cardiac cycle here. Biochemistry was doing cardiac enzymes here, right? And similarly for the second year, let us say that microbiology was dealing with Mycobacterium tuberculosis here. Pathology was looking at Ghon's focus here, and pharmacology was doing anti-tubercular drugs here, right? So there was a disconnect between the different subjects. And the first attempt of CBME is to align the topics. That means the topics that are related are done concurrently. So this is alignment. And I think all medical colleges now have tried to align their curricula as much as possible. So what is mentioned in the GMR document is that alignment should be done as much as possible. So this is alignment. The next thing is, after alignment is done, there have to be a few linker sessions for some important topics. So a linker session deals with sharing and correlation in the Hardin's ladder. So typically what is suggested is that a case is discussed, like the example I gave you before, myocardial infarction, let us say, and that case is discussed and unifies the subjects, anatomy, physiology, and biochemistry. Here, for example, tuberculosis. you discuss a case scenario related to tuberculosis and try and unify a pathology, pharmacology, and microbiology. Right? So here you can have diabetes, you try and unify surgery and medicine. Okay, so this is a linker session, and it is mentioned that a maximum of 20% of time of the curriculum is to be allotted for linker sessions. And of course, as much as possible, we need to do nesting. I think that is under our control. So for example, this is anatomy. I try and nest some surgery whenever I teach anatomy. And it would be a good idea to actually meet the surgeon before you decide what to nest in your session. And similarly, the surgeon can meet the anatomist and decide what aspects of the inguinal canal to talk about when they are looking at a patient with inguinal hernia. So this is called nesting. So this is one easy way of introducing vertical integration into the curriculum. So the last part of this session is about the logistic details. Again, many of you might have already attended the CISP programs in your colleges. So pardon me, it might be a repetition for all of you, but for some others, it might be important. So there is a curriculum committee in each college, right, which consists of preclinical, paraclinical, and clinical faculty and students as well. And what is suggested is you create topic teams. So I just give you an example. A topic team could be anemia. I'm going to look at that example. Let's say that you create an anemia topic team. And that could include, let's say, faculty from physiology, from biochemistry, from pathology, from microbiology, from general medicine, from OBG, and community medicine, let us say. Then that topic team will have to look at, okay, so each topic team is in charge of one topic, I said anemia. And the topic team then needs to go to the competency book, that is volumes 1, 2, and 3, and make a list of all the competencies from anatomy till medicine and surgery of all the competencies related to anemia. Right? So once the topic team does that, then comes the writing of specific learning objectives. For all those competencies identified in relation to anemia, specific learning objectives have to be written. And once the specific learning objectives are written, then it will become clear about which department has to deal with which objectives. And you can also then look at where to introduce linker sessions, where to do nesting, where to do sharing. All those decisions can be made, and alignment as well. And the topic team then has to liaise with the faculty who are creating the timetables in order to ensure that all these aspects can be fit into the schedule. And the topic team provides support for implementation, and this whole process goes on. And just as a suggestion, I think all medical colleges, it's quite a daunting task. Perhaps it would be best to start with 2 or 3 topics initially to try and follow this process, and then look at more topics for integration in the future. So with that, we come to the end of this presentation, and this is what we explored. We looked at the need for integration, and we said that neurons that fire together wire together, and the Indian medical graduates should be able to treat patients, and for that they need to be able to connect all the information that they learned in medical college. So that's the compelling reason of why integration is required. What is integration? Basically, we looked at horizontal and vertical integration. Horizontal integration is integration in a particular phase, whereas vertical integration is across phases. And there are many ways of doing it. You can have topics, you can have systems, or you can have case scenarios. And the how of integration, we looked at Hardin's ladder to guide us through the 11 steps. And the 4 steps that are relevant in the Indian context are nesting, alignment, sharing, and correlation. And we briefly looked at how the topic teams play a key role in implementing these curricular changes in relation to integration in the Indian context. So I end with this. We all think that we are very small and we cannot create change. But if each of us create small changes in our departments and we do that all over India, there will be a big change. So with that, I would like to end my presentation. Thank you so much. I would once again like to thank the organizers for inviting me and the participants for your patient hearing. Thank you.
Thank you, sir. That was an elaborative session. You made us clear that we need to move from our compartments. We can't stick onto a compartment and it should be integrated. And you started from the basics of integration, right from anatomy and physiology, and you explained the various methods of alignment and integration. It's nice to have you, sir. There's a question for you.
Yes, sir.
How to conduct integrated assessment? And
Yes.
if done, can it be done in summative assessment?
Okay, so I think that's an excellent question. So integrated assessment can be done in formative assessment. There's no doubt about it. So just to give you an example, we had a faculty member here who did team-based learning in relation to an dissection of the thorax, anatomy, physiology, and biochemistry in relation to the heart. And what they did was the team-based learning itself has an assessment component incorporated into it, which is integrated in nature. So I think formative assessment, as far as integration is concerned, is not a problem. Of course, there are those logistic issues of where to include the marks if we have a formative assessment. All those issues can be sorted out. At the summative assessment level, sir, we are still not at that stage of having an integrated summative assessment. But certainly, I think having clinical case scenarios as part of our assessment, in some sense, provides some amount of integrated assessment. Though I do agree it still is related to a particular subject, but that's a step in the right direction.
One more question, sir, from the
Yes.
participant. Whether nesting is possible in the present scenario? Probably COVID time, I think. The question is
Okay.
whether nesting is possible in the present scenario.
Yes. So I think nesting is of the four the easiest. Like the example that I gave you, any medical college teacher can very easily do nesting because it's very easy to, because most of us are medical doctors, or if you're not medical doctors, we still have the medical context in mind. So just to, like the example that I gave you, if I'm taking a class on inguinal hernia, it is very easy for me to talk about, inguinal canal, anatomy of inguinal canal. It is natural for me to talk about inguinal hernia and provide the relevance to what I'm teaching. So I think nesting is the easiest to do, and all of us can do nesting.
Thank you, sir. I would like to share the certificate of your presentations as a speaker, sir. Just 1 second. Yes. So kindly accept the certificate from our
Okay, thank you so much.
organization.
Thank you so much. Thank you.
Thank you, sir. Thanks for joining us. With this, we'll move on to the next session, which is on early clinical exposure, which we have tried in the last batch itself. In the first batch, we have started this program. So then, I'll let you know about the speaker. 1 second. Yes. So the topic will be taken by Dr. Mrs. Sunita Jain Vaga, a FAMA Fellowship and PhD in Health Professional Education. Madam is currently the Professor and Head Department of Pathology, JNMC, uh, Dean Academic Faculty of Medicine, D, DMIMS. She is ex-Director School of Health Professions Education and Research and the ex-convener of the MCI Nodal Center. She is faculty of MCI Nodal Center GNMC and also national consultant for MCI. She has many national and international publications in the field of pathology and also medical education. She has 28 copyrights and has many publications. The title of our presentation is Early Clinical Exposure, its Implementation. Thank you for having coming here, ma'am. Over to you. You can start, ma'am. You can share your screen
Yeah.
and you can start.
So at the outset, I thank the organizers and the organizing team for giving me an opportunity to interact with the delegates on early clinical exposure and its implementation. So thank you so much. So we will move on to the topic. I'll be taking up discussing this topic in two parts. The concept about the early clinical exposure and its implementation, how to implement early clinical exposure at institutional level as far as the council's guideline. So I'll be discussing it on the rationale of ECE, concept of ECE, how to design a ECE module, and planning of ECE implementation at institutional level. So the word early clinical exposure comprises of two words, early and clinical exposure. Early means what should have been traditionally regarded as a preclinical phase is usually the first 2 years of the medical curriculum. And the clinical exposure means it is the authentic human contact in social or the clinical context that enhances the learning of health illnesses and or diseases and the role of health professional. The Flexner's report in 1910, which is considered to be a landmark in medical education, emphasized the study of basic sciences should be integrated with the clinical sciences. We know that the clinical exposure is an important part of health professional training. The challenge for medical professional education is to search a way for ways to enhance the quality of clinical education. Nowadays, a hospital-based education system has covered a wide variety of learning environment. So, what is clinical exposure? As far as the literature says, the early clinical exposure is a teaching learning methodology which fosters the exposure of the medical student to the patient as early as first year of medical college. As we know, the curriculum of medical curriculum is designed in such a way that we have a preclinical phase, paraclinical phase, and the clinical phase. The contact with the patient or the clinical exposure starts from the paraclinical phase. The students are away from the patients or they are not exposed to the patient in the preclinical phase. They are just exposed to anatomy, physiology, and biochemistry, which are the preclinical subjects. So when we expose our students by using a teaching learning methodology, which fosters exposure of medical student to the patient in the first year, that is the preclinical phase, is called as early clinical exposure. Why this early clinical exposure is required? You can presume if the student attends a lecture, don't go that. It is just an example I have cited here. The lecture is taken by the Krebs cycle. You can see the students' reaction to this. Some of the students says, why do I have to learn this? Other student says, it is so boring. And third students come out with, I thought I was learning to be doctor. I took admission to the medical course because I wanted to become a doctor. Why you are teaching all these things to me? This is a general reaction of the student who seeks admission to the medical course. Again, I am sorry for the subject specific examination. Pardon me for this. I just wanted to introduce you or need emphasizes on the need for early clinical exposure. So when you expose your student, maybe any preclinical subject, the reactions are like this. Why do I have to learn this? It is so boring. I thought I was learning to be a doctor. At the entry point of MBBS course, the students have little knowledge and experience of medicine. They look forward to dealing with the patient and learning how to take care of them. They find it difficult to correlate the preclinical subject without seeing the patients and understanding the purpose of learning. And when they are forced in such a situation where there is no correlation between the preclinical and the clinical exposure, this situation generates a lack of motivation to the study individual preclinical subject, and in addition does not foster the integrated learning and thinking. Hence, the curricula are to be integrated in such a way that early clinical exposure is introduced along with the basic sciences so that students learn both basic and the clinical sciences. Early clinical exposure ensures well integrated knowledge of basic sciences, clinical sciences, and social function. The key principles underlying the early clinical exposure are providing the clinical context and ensuring the patient centricity. So we have seen when the students enter into the preclinical phase, they have in their mind if we want to become a doctor and we will be treating the patient or we will be examining the patient. But contrary to this expectation, when they come into the preclinical phase, they have been exposed to the classroom teaching. They are not aware about the patient or the hospitals or the ward. So that creates a naturally a boring situation for them because this is away from their expectation that unmotivates them towards developing the interest in the preclinical subject, and at the same time they find it difficult to integrate it with the clinical subject. So the concept of early clinical exposure, if this can be introduced, this will definitely expose the student in first year of life. Plus, it will try to integrate the basic subjects with the clinical sciences, and it will provide a clinical context and assuring a patient centricity. So we can say that the early clinical exposure acts as a bridge between the preclinical disciplines and the clinical disciplines. So the passage of students from preclinical to clinical disciplines become very easy as we introduce the concept of early clinical exposure. So the goals of VC are to provide context and relevance to basic sciences. At the same time, there is gain in the medical knowledge, few basic skills, and wide range of attitudes. We are aware that whenever the students entered into the medical college or they are exposed to the medical curriculum, it is a duty of medical curriculum to bring about the changes in the knowledge, skills, and attitude of the learner. So the objectives of early clinical exposure are recognize the relevance of basic sciences in diagnosis, patient care, and treatment, provide a context that will enhance the basic science learning, relate to the experience of patient as a motivation to learn, recognize attitude, ethics, and professionalism as integral to doctor-patient relationship, and understand the socio-cultural context of the diseases through the study of humanity. These are the objectives of early clinical exposure as far as the module of the council. So coming to the early clinical per se, how it should be introduced. There are three elements of early clinical exposure: basic science correlation, clinical skills, and humanities. We will see one by one. Basic science correlation means to apply and correlate the principles of basic sciences as they relate to the care of the patient. In the clinical skill component, to include the basic skills in interviewing the patients, doctor patient communication, ethics, professionalism, critical thinking, analysis, and self learning. And as far as the third component, that is humanity, to introduce learner to a broader understanding of socio-economic framework and culture context within which health is delivered to the study of humanities and social sciences. So when we want to how to introduce and where to introduce this early clinical exposure, there are three settings where we can introduce it. One is classroom setting, other is hospital setting, and third is community setting. The classroom setting means the case discussion. You can bring patient to the classroom. That is the patient brought to the classroom. That is a classroom setting. We will see how it should be conducted. Hospital visit or visit to primary care hospital provides a hospital setting. Means you can have a coordination with the faculty members on the hospital side or primary care hospital, and you can take students to the hospital. And third setting is community setting where you take the students to the community. In my institute or at our university, we have a community partnership program where which is organized by the Department of Community Medicine. Here, the first year students on every Saturday, they have been taken to the adopted villages so that they have been oriented towards the community or the social contacts. So these are nothing but the community visits. So training in basic skills along with the classroom setting, you can post your students into basic skill lab or you can demonstrate the clinical problems. So there has to be a context and the relevance with what you are doing. So again, I will summarize. The EC can be conducted in the classroom called as classroom setting, or you can take students to the hospital called as hospital setting, or you can take students to the community called as community setting. During the classroom setting, you can directly get the patient or you can get the paper-based scenario. We will see what all modalities can be used in classroom setting. In addition, you can post your students for training in the basic clinical skill, and along with that, you can demonstrate them the clinical problems. In classroom setting, the best or the ideal way is to getting the patient to the hospital. If the patient is ambulatory, if GC provides, you can directly take the patient to the classroom. Or if it is not possible, then you can create the paper-based cases, that is the clinical cases. Along with that, you can show the clinical photographs, you can show the laboratory investigations report, you can demonstrate the ECG report, you can take the X-ray. But you need to correlate this or coordinate this with the topic of your lecture. Suppose you are taking a lecture on the enzymes which play cardiac enzymes, then naturally you need a case of myocardial infarction. So you can create a case, not possible to get the patient to the uh, class. So you can show the history details, examination finding, and you can show the laboratory reports or the ECG findings of the patient so that student get a perfect picture of a case of myocardial infarction and they can correlate it properly the enzymes cardiac enzymes and their role in diagnosis of cases of myocardial infarction. This is how the students can be exposed to the clinical scenarios in the classroom setting. If possible, get the patient; not possible, create the paper-based cases. What is the role of these cases? The cases provide a focus for learning. Suppose I am teaching, like I'll go to the classroom setting and teaching my students the role of cardiac enzymes in the diagnosis applied aspect of the cardiac enzymes. So here, if I show them clinical details of the patients of myocardial infarction, if I will show them the laboratory data of the patients of myocardial infarction. So these cases will create a focus for learning. Now the student can correlate, yes, this is the enzyme which increases in patients when they come to you in the hospital with the history of chest pain and the diagnosis is myocardial infarction. So this is how the cases provides a framework for the discussion. For this discussion, the case is not a textbook or a syllabus. So it's not boring for the students. And usually, like just now I have quoted, the selection of case must match the objectives of your session. What do you want to teach your students? Accordingly, you should pick up the case. Suppose I want to teach the long bones, I can pick up the cases from the orthopedics department, that is fracture femur or fracture neck femur, and accordingly I can show it to the students, the x-rays, then the clinical details, and the students are able to correlate it properly. That is the roles of the cases. Then these are the contents, the how you, when you are preparing the EC, what is a sort of clinical training, what is the role of social sciences and community health training you will be using. So the training in basic clinical skill, uh, this can be done demonstration on the patient or you can show the movie on demonstration. The students, if it is not on the patient, you can ask the next patient for the demonstration, or you can ask the students to practice in the basic skill labs. The clinical problems can be discussed by showing the cases, by taking the students to the laboratories, observations on the interventions like endoscopies or surgery, or you can create the paper-based or the problem-based cases called as problem-based learning or case-based learning. Social sciences includes usually the communication, ethics, and professionalism. So here you need to concentrate on the doctor-patient relationship, interpersonal communication, how to cope up with the stress and the work pressure. This can be done by posting your student into the communication skill lab. We have a skill lab of its own kind at my university, where we are regularly posting our students for communication, ethics, and professionalism. And this we have started prior to the ATCOM module by the council. So here we have 2 days module for first year student, 5 days module for second year and final year students, where we emphasize on doctor-patient relationship, interpersonal communication, coping with the stress, then behavior with the society and all. And at the same time, you can inculcate the ethics and professionalism by the good professional attitude attributes and common by showing them the cases of common ethical dilemmas. This entire training can be done by setting a simple communication skill lab. And third is the community health training. Here you need to take the patient to the society where you can teach them the common health problem, understanding the community health, health education, health bill, biostatics, and the vital statistics. So this is how you can go ahead with the various scenarios and you can teach your students by exposing them into the classroom setting, hospital setting, or community setting. The various teaching methodologies which can be used while training your student through early clinical exposure, small group methods, teaching clinical skill, or you can have the clinical laboratories like basic skill lab, advanced skill lab, communication skill lab, or you can take them to the hospital, coordinate with the teachers from the clinical departments so that the students can be exposed to the clinical cases in the beginning. The self-instructional material can be created and shown to the student. We need to assess the students if, and this is the rule of education, that what we are teaching we need to assess, or rather we should assess what we have taught. So early clinical exposure can be tested in the internal assessment as well as in the summative assessment. As internal assessment is at the beginning, so you can think about the clinical correlation in the basic sciences by creating the problem-based questions or level 2 questions. And in summative examination, a little bit hierarchy, application of basic science knowledge in the clinical context, again through level 2 question. I'll just show you a few examples. A 30, like you can give a history along with certain laboratory findings, and you can ask the question, what is the probable diagnosis, what can be the causative factor for this condition, differentiate various types of jaundice, enumerate the important liver function test, or you can just provide the laboratory data and you can ask the question. So this is a long answer question. Similarly, the short answer question of 6 marks can be created by providing the history, and you can ask, describe the biochemical test associated with these conditions. This is how you can assess your student as you are exposing them to the clinical cases. The assessment tools which can be used, you can take the feedback of the student, you can ask students to reflect, you can create the logbooks. Like now it is mandatory for the students to have the logbook. So in the logbooks, you can create the areas for early clinical exposure where you can ask your students to reflect. You can also take the feedback after the sessions of early clinical exposure. The early clinical exposure can be assessed through the MCQs, short answer question, long answer questions, even through the vivas, through the OSPI and OSCE. These are the various assessment tools which can be used. Now coming to designing of ECE module. The selection of state overall goal, learning objective. This is a format. These are the various steps. Plan the learning experience, plan for implementation, plan to overcome the challenges, and plan evaluation of ECE. These are the 6 important steps one need to follow while designing the ECE module. This is a format which you can use. You can use the setting, whether it is a classroom, hospital, the topic of basic sciences, like suppose it is through biochemistry, you are teaching acute myocardial infarction, then what is the goal, expected competencies, objectives, then the learning experience, total time duration as far as council is 3 hours. So it can be through classroom, you can create the facilitator guides, you can suggest the assessment modalities. You can ask students to reflect by creating the questions like what happened, so what next. The program evaluation can be done by taking the feedback from the faculty as well as from the student. At the same time, you need to put the resources for the particular case scenario. I will just show you an example of the module prepared by our biochemistry department on jaundice. Okay. So very sorry for the technical problem. I can show you the problem. This is a module which was taken on the topic of jaundice, which have included, this was a classroom based module where we have selected a competency from the curriculum, and accordingly the each step was mentioned as far as the format. Now coming to the last aspect of my lecture, that is the implementation of early clinical exposure, how it should be done. So the first part of implementation is the capacity building of the faculty. This should be done through the faculty development program, and it is a responsibility of a medical education unit where you need to orient to the principle and practice of ECE. Faculty from pre and paraclinical subjects needs to be coordinated and involve the activities related to hospital visit. The clinical faculty may be involved. The faculty should be trained to develop, implement, and assess the ECE. And the task like setting question paper, use of case-based session, all this, in this task, the faculty should be included. Then when you plan the ECE, the basic sciences, it should be in across all basic sciences around the clinical scenario. As far as GMR 2019, the time allotted for ECE is 90 hours, and it has been equally distributed in all the three subjects, that is 30 hours per subject, that is anatomy, physiology, and biochemistry. For each subject, these 30 hours can be distributed. Basic science correlation 18 hours. So you can plan a 3-hour session per month for the initial 6 months. For clinical skills, that is experience in human context, the 12 hours are allotted. So you can plan a 3-hour session for the 4 months. For humanities are concerned, it should be merged with the ATCOM. So no hours are allotted for this. So how to do the monitoring? The dean is at the apex. The overall responsibility of the dean is to monitor the implementation of ECE. Then comes the medical education unit. The responsibility of the medical education unit is the capacity building of the personnel involved in conduction and coordination of the most of the responsibility lies with the curriculum committee of the institute, which comprises of the faculty member from each phase, which looks after planning and implementation. And the coordination is the responsibility of the heads of the department. This is how the hierarchy for the implementation and monitoring. The responsibilities of the dean is to conduct the regular meetings of the curriculum committee and head of the department and ensure the implementation of ECE and monitor it. MEU is to organize the faculty development program. The curriculum committee, the whole sole responsibility is of the curriculum committee to plan, conduct the ECE sessions as per the guidelines. Responsibility of the head of the department is a coordinator for ECE program. So this is all from my side. Sorry from some technical problems which has delayed my session for a while. So I have referred the module 2 on clinical exposure by for the Indian medical graduates, that is from MCI. I acknowledge the contribution help from the members of my nodal center. So let us be partners in the change. Thank you very much. Again, I extend my sincere thank to the organizers for giving me an opportunity to share my views with you. Thank you very much.
Thank you, ma'am. It was indeed good when you were saying how to link this basic sciences to the clinical sciences to different level at the classroom, bedside, and also at the community level. And you explained us about how to assess this EC. This was something everyone had in their mind, how to assess this EC, or it is just a part of teaching. And you also showed the implementation part. Thanks a lot, ma'am. I
Thank you.
could not find any question. One second. Q&A. Yes, I have a question for you. How ECE
Yes.
can be conducted in the COVID-19 situation?
So EC can be conducted in again on an online mode, and by and here you can show the case-based cases to the student, paper-based cases. You can show them the photographs and all, and like we are conducting this virtual seminar, so you can show it to the student, and it can be conducted through this. We just have an option of the paper-based cases.
Yes. Thank you, ma'am. Thanks for the answering. Ma'am, kindly, ma'am, can you stop sharing your screen?
Yeah. Sharing stop.
Ma'am, we tried to present a certificate for spending our time and explaining about the early clinical exposure with us, ma'am.
Thank you, sir. Thank you very much.
Thank you. Thanks a lot, ma'am.
Thank you.
With this, we'll move on to the next scientific session. Though as per schedule, it was a lunch break, and we will just continue. We had only 10 minutes as lunch break, so it's a virtual thing, so we can continue for want of time. We have the next speaker also. Yes. So let me share the screen about the next
Yes.
speaker. Yes, sir. One second, sir. Yes. So our next speaker from JIPMA, we have Sir Doctor is Zaya Prakash Rasan. Sorry if I pronounced it wrongly, sir.
Jayaprakash
Sir,
Rajan.
so can you tell it again?
Hi. I'm Jayaprakash Rajan. Actually, it's written in French. So in
Oh, nice.
Pondicherry, we have the custom of writing spelling in French.
Okay.
So you can pronounce it as Zaya. No
Yeah.
problem.
Okay, Zaya, sir. Okay. Sir is the additional professor and convener of the MCA Regional Center JIPMA. He's also ATLS educator and FAMA fellow. In the Department of Medical Education, JIPMA Puducherry. Sir is going to present on how engaging remote learners in medical education. I think an apt topic at this situation. Over to you, sir. Nice to have you with us.
Thank you. Thank you, Dr. Balaji, for your introduction. So let me share my screen now.
Yes, sir.
So it says you cannot start. No, there is no permission for me to share my screen. Can you please permit me?
So you can, sir. I just stop sharing. Can you try again?
Yeah. Thank you. Is my screen visible?
Yes, sir.
Am I audible? Okay. Fine.
Yes, sir. Thank you. You can
So
proceed.
a very good afternoon to everyone. And at the outset, I thank the organizers for giving me this opportunity to speak on this topic. So this now, before I just go into, I go into deep into the topic, I wanted to give a brief introduction about this topic, the background information about the topic. So if you just see here, this picture depicts some 20-30 years back. We were dependent on this slide. And after that, a lot of innovations have taken place in the field of education. And now we are in the age of what we call this information and communication technology age, or the era of ICT. And some even just few years back or few months back also, our people are not fond of using this tab or mobile. But now the whole classroom is there inside this tab or mobile. I think all of you will be agree. You all will agree with me. So once the technology which we said should not enter into the campus, now it is the technology that has allowed the whole campus, the whole institute or the college or school inside this small gadget. So with this short background information, trigger, let me move on to the objectives of this session. for the next 30 minutes, I'll be discussing about who is a remote learner and what is remote learning, what are the remote learning, how to engage, what is meant by learner engagement, what are the factors influencing learner engagement, technological tools for learner engagement, and success indicators of learner. These are the topics which I'm going to deal for the next 30 minutes. Now, the next thing is, before we talk about the technology, remote learning, distance education, technological innovations, I would like to briefly tell you about the four revolutions that had already, four major revolutions that took place in education, the field of education. The first revolution being changing the responsibilities of education from parents to teacher and from home to school. This is the first revolution. This took some thousands and thousands of years ago. So where there were more teachers, then after that we identified, the humankind identified some people as teachers, and the responsibility of teaching was bestowed with these so-called teachers. That was the first revolution. So that before that, only parents were doing the job of what, teacher. So this is the first revolution, and from parents to teacher and from home to school, it was transformed. And the second revolution is the replacement of oral instruction by written words. After the discovery of, after man started during the course of civilization, man started writing, man started inventing words and other things, and that became the second revolution. And that also revolutionized the field of education. And the third revolution is the invention of printing press and subsequent availability of it. This is the major revolution that stood for a longer period. Even now, it is one of the major source. So this invention of printing press enabled the teachers and the content creators to create a lot of content in the form of textbooks, and that created a big revolution. And now the current situation is, so everything is now whatever we believed the books as, the library, which once upon a time all libraries used to hold thousands and thousands, lakhs or millions of books. Now all these libraries are slowly being shut down, and then they are converted into e-learning centers. Okay, so that is the fourth revolution, invention of electronics that led to the application of mass media and ICT, information communication technology. Otherwise, this revolution is called as the gray revolution. It is because of information explosion and advancement of technology. The gray revolution here refers to the gray matter of our brain. Now it is very easy to get information, very easy to process it, very easy to assess it. So a lot of things have made this advancement in technology has made things very easy. So with this, let me move on to the term what is remote learning. As our topic is strategies for engaging remote learners, remote learning in medical education. One of the important term in this the topic is remote learning. So if you look at this picture, so once the teacher was physically present in a classroom, now most of the teachers are virtually present. Virtually, they are inside the computers or inside they show their presence virtually in some form of gadget, through some gadgets. So that is one thing. And thanks to the transformation agent, the COVID, we call the COVID as a transformation agent. Thanks for COVID. Not only COVID, the term remote learning is not new. Maybe for us it may be new, but it is already there for the last 2 decades. It is in the form of it is called as distance education or remote education, remote learning. So a lot of other terms are there, e-learning. But this has gained momentum because in India and almost across the globe because of the COVID-19 situation. And now we are not going to again we are not going to go back to fully traditional classroom. Even if you go back to the traditional mode of learning, teaching and learning, this remote learning is also going to become part and parcel of our routine classroom. That's what I would like to say through this. And who is a remote learner and what is remote learning? So when the teacher, a student, teacher, and information source are not physically present in a traditional classroom environment, it is said to be remote learning, and the learner is called as a remote learner. And in remote learning, the time, it is separated by time and distance, and information is transmitted via some technology. Either it can be in the form of email or discussion boards or video conference or so and so. A lot of other technologies are also there, and it can be either in the form of hybrid or blended learning. So hybrid is that which includes both traditional and online method of learning. So the other name for hybrid learning is blended learning, and it can occur synchronously or asynchronously. When See, now what I'm doing is a synchronous session. So when it happens, when the session happens real time, it is called a synchronous. And if the same session is put in a form of recorded in the form of video and it is mailed to the participants and they look at it and then they get back to the teacher with some comment, then it becomes asynchronous. It is a kind of store and forward. So synchronous is real time and asynchronous is, of course, it is also online, but it is not real time. And also referred as distance education, virtual instruction, remote learning. These are the other names given for remote learning. Now, what does it mean to engage? The next word in the topic is the engaging remote learners, the engagement. What do you mean by engage? So engage refers to engaging our learners. So we have a lot of sense organs, I mean, not a lot of, we have many sense organs, say major 5 sense organs, ears, eye, nose, skin, tongue. So all these sense organs help us to process the information around us. So are we effectively using these sense organs in our traditional classroom? The question is no. Frankly, if you think and then say it is no. Okay, so that is what. So engagement here refers to engaging the sense organs. The more you engage your sense organs, the more information is gathered by our learner, and this helps the learner to process the information and then use the information in the form of knowledge or attitude or skill. So what does it mean to engage? In education, the student engagement refers to meaningful student involvement throughout the learning process. So what is meant by meaningful student involvement? We are every day the teachers are taking lectures in their lecture halls. So how many of us have ever thought of whether my lecture is meaningful, whether my students are getting meaningful information, whether my students are processing this information into a meaningful learning? Are they able to convert this information into knowledge? Are they able to generate evidence for having converted this information into knowledge? So this kind of thing, have you ever thought of it? Even if you have thought of it, have you ever implemented it? So that is a big question mark in our system. So the next engagement, it also refers to the degree of attention, curiosity, interest, optimism, and passion that students show when they are learning or being taught. So when you say you are engaging a learner, it should motivate your learner, it should increase the curiosity, it should sustain their interest, it should, it should make them to involve more and more, it should make them to respond, receive your information, respond to your information. These are all the indicators to say that you are engaging your learners. The learning encounters that facilitates to acquire knowledge, attitude, and skill. So in other words, engage also refers to whatever learning encounters you provide to your that is provided to your learner. So that should help them to acquire knowledge, attitude, and skill. Otherwise, it is called as a learning set. And the current term what we are using in MCA is the competency. Whenever you say the word competency, it is not as a separate entity. It includes all the 3 major domains, that is knowledge, attitude, and skills. Right. Then it also says that engaging means facilitating learning through effective use of sense organs. So unless you unless you help your learners, to effectively use their sense organs, it will not be easy for them to process the information provided by the teacher. Then it also says that quantity and quality of learners' participation. So these are all the definitions for engaging. When you say engage, many of these things should happen in your classroom. Then only we can say that as a teacher, you are engaging a learner, or as a learner, your learner is engaged in a meaningful way. So why is it important to engage our learner? So the reason, all of you know, it's very obvious that we have our own curricular objectives. That is one reason. Second thing is we have our own objective. The learner have their own objectives. That is another thing. So research has demonstrated that effective and purposeful engagement increases the span of attention, the attention span. So the normal attention span of human beings, the focused attention span is only 8 seconds, and the sustained attention span is not more than 20 minutes. That is why if you look at the TV advertisements and all, they don't exceed more than 8 seconds like that. But if we engage our learners purposefully and in a more meaningful manner, definitely that will increase their span of attention. Then that also helps them to sustain their interest in the topic or the subject that is under discussion, and provide motivation to practice higher level critical thinking skills. If we actively engage our learners, and that will open up their mind, and then that will make them to interact more and more with their fellow members or teachers or the object that was given to them, so that will help them to use their higher order thinking skills or critical thinking skills, and it also leads to meaningful learning. So then So whenever you say student engagement, that means we are talking about an engaged learners. When you say the learner is a learner is engaged, it requires four pillars. So the first pillar being these are the four pillars. The first pillar being the personalized learning. So you may think that how can I, in a class of 150 students, how can I personalize my teaching to each and every student? That's a very good argument. But at the same time, we can think of pluralizing our presentation. So you have a content in hand, and we always go with the PowerPoint only. That is only one format we have, or we stick on to the podium and then we start delivering the lecture. So other than these two, most of the time we only stick on to these two methods. So here, what they say, personalized system of learning here is that not just personalizing each and every content to each and every learner. So whenever a teacher enters into a classroom, he or she is expected to pluralize his presentation. The same content in the form of a PowerPoint, same content in the form of a mini lecture, same content in the form of an activity, same content in the form of a case-based scenario, okay, the same content in the form of a group discussion, same content in the form of a video, same content in the form of a demonstration. So lot of avenues or opportunities are available to convert the a single content into different formats. So that is what it says person. Suppose as a learner, if I'm not comfortable with one single format, I have an option to choose another format for my learning. So that is the first one. Second one is learning without limits. So for example, in small group discussions and all, there is no limit for the learner. So his mind is open and he can argue, he can what is it, put forward his ideas, he can come out with suggestions, he can solve problem, he can think freely. So opportunity should be given for the learner to what, think without limits. So that is again one of the pillar of student engagement. And the third pillar is student driven learning. When all these things happen, say for example, go back to your lecture session and see whether is there any opportunity for a learner to make him to make that particular session as a student driven session, or to make the whether your lecture session is making your learner to learn the same content in a student driven manner. No, because in a lecture session is a one-way method, and we just deliver the content and then we just like that move out of the hall. But we don't check whether the learner has learned, if he has learned, what kind of learning has taken place, what is the evidence for that. But in student driven learning, you are giving opportunity for the learner to think, listen, read, write, discuss, solve problem. All these things will help the learner to look forward for the next level of the content, and he himself or herself will decide, okay, what is my next level, where can I get the next level of content, how can I learn. So that makes them a self-directed learner. That is called a student driven learning. So whenever we teach, we should make always assure that our students are slowly becoming student driven. Okay, then the last one is the competency based learning. So why this competency based learning is very important? Because in competency based learning, as I already said, it is not only knowledge, not only attitude, not only skills, it is a learning set. So when you say competency based education, it the conglomeration or the combination of knowledge, attitude, and skill. So at the end of the day, when you say your learner has learned something, you have taught something, your learner should have learned something, and your learner should be able to demonstrate or exhibit that knowledge, attitude, and skill. Then only you can say that your learner has been properly engaged. That is why this competency based is considered as one of the pillar. Now, then only you can say that your learner is engaged or engaged learner. Coming to the dimensions of learner engagement, these are the three major dimensions. There are a lot of other dimensions. These are the major dimensions of learner engagement. One is the cognitive engagement. Here we are engaging the central level, the brain, the cognitive part of the thing. Here we give the knowledge base, that is the knowledge base about the topic under discussion. So that is called as cognitive engagement. Next, here in cognitive engagement, the engagement can be in the form of questions, engagement in the form of a lecture, engagement in the form of reading, engagement in the form of writing, engagement. So what all cognitive skills can be brought inside here. It's not that only you are expected to give only one cognitive skill. So because lecture is also one of the cognitive engagement only, but lecture alone will not help our learners. As I said, reading, writing, listening, active listening. So all these things are the cognitive engagement. So one content in different formats. The next engagement is the emotional engagement. As a teacher, we should try to connect with our learners through feelings, through emotions, through actions. So all these things will connect our learners with our feeling, and it will appropriately help them to apply these emotions to the content. So that is called as the emotional engagement. How frequently the learner attends, listens to you, receives your information, respond to your information, whether he recognizes the information. All these things are related to the emotional engagement and how he reacts to the information like that. Then the third dimension is the behavioral engagement. It says that behavioral engagement refers to how frequently the learner attends your classroom, your session. It's a behavioral engagement. He is regularly attending. If he is regularly attending, what is the reason? To escape other classes he is attending, or to really he is fond of your class? So that is called as behavioral engagement. Whether he is interacting with the other fellow members, and whether his reading habits has improved, whether his teaching hours have improved. So all these things can be classified under behavioral engagement. So cognitive engagement, it engages the brain. Emotional engagement, it engages the heart, that is the attitude. And the behavioral engagement, it engages, it modifies, it transforms his behavior towards higher order learning. That. So the engagement process should be like this. It is expected to be like this. So here, the teacher is here. The second component is the content, and third component is the learner. So what it says is that as a teacher, first of all, we have to establish connection with our content. Say, as a teacher, always we have a content to communicate to our learner. So you cannot just like that take a content and then we cannot communicate with our learner. Then it is not meaningful delivery, or so meaningful learning cannot happen. So that is why the field of the art and science of education comes here. The art and science of teaching comes here, which you call it as a pedagogy. So a teacher should be well versed in pedagogy. Though the content is already there, the teacher should be well versed or skilled enough in identifying appropriate teaching learning method to convert this content into appropriate transactional strategy. So as a teacher, you have a content and you should be familiar with the pedagogy, that is the art and science of teaching. So the content is now converted into a transactable content. And now this is called as the connection of the teacher, the establishing connection with the content by the teacher. So unless you establish relevant content with your relevant connection with your content, you cannot establish connection with your learner. Okay, now going to the learner. Now having established right content, association or connection with the content, we are going to transact it to the learner. So how are we going to transact the learner? Before that, we have to establish connection with the learner through this content. So how to establish connection with the learner? So through interaction. When you interact with the content, with meaningful activities, convert the content into activities, and then make your learners to involve in this, then your learners will feel that, okay, it is worth studying this content, and they'll find the content is relevant to them, and they'll show more and more interest, and they will look forward for your class. And not only that, they themselves will become what we discussed in the earlier is that this learner self-directed learning. They will push themselves towards self-directed learning. So that is what it says. So a teacher, content, and learner. Teacher should be well versed with the pedagogy. With the help of the content, the teacher the content is converted into a transactable content according to the needs of the learner. And when the teacher tries to establish connection with the learner, he connects the learner through meaningful interaction. So the learner finds it very relevant for him or herself, and that makes that learner as an engaged learner, or this is called as engagement with the learner. Right. So this is the most popular cone. I think most of you may be aware of this cone, which is called as the Edgar Dale's cone of experience. Why I'm showing this cone is this acts as a framework for identifying the appropriate teaching learning method for engaging our learners. See, the first half of this, not the first, the first four sections, that is from 10% to 15%, the learner is involved passively. There is no active involvement of the learner. Why? Because here the learner is only at the receptive end. So he reads, he hears, he sees, and he uses both seeing and then hearing. It is only he is at the receptive end, and he has no role to create something, analyze something, solve something, discuss something. So that is not happening here. Okay, but the last two things, there is ample opportunity for the learner to think, learn, reason, judge, solve problem. All these things can happen in the last two sections. That is why it is said that the last two sections indicates active learning, and the first four sections indicates passive learning. So when you say that you are engaging your learner, it should be active engagement. So always think that make use of this cone of learning and identify appropriate teaching learning methods. So for example, if you are going to do a presentation, a demonstration, then it comes at the last point. If you are going to use a simulator, in a simulator, you get opportunity for, you are providing opportunity for the learner to do and learn. In a discussion, you are giving opportunity for the learner, open opportunity for the learner to think, read, write, and then discuss, elaborate the problem, identify possible solutions for the problem, share the solution with the next person or the other person. So, and he receives feedback from others, and he refines the problem. And finally, as a group or as an individual, they reach a final solution for the problem. So when all these things can happen, so knowingly or unknowingly, the learner is dynamically involved in the process of what? Learning. So which you call it as an engaged learner or engaged. So, but in the other four things, the learner is only a receiver of information. That's all. Okay, so again, I would like to say this is a framework for identifying appropriate teaching learning method depending on the level of engagement you want to engage your learners. Now, these are some of the model engagement strategies. I have just given briefly only the three things. There are also other strategies. So with reference to the content, if you want to engage your learners with your content, there are different ways how you can engage. Apart from the traditional textbooks, printed textbooks, you also have web pages, internet resources, video calls, podcasts. So say, for example, you have a content, make a video cast and then broadcast this. Make a podcast and then broadcast it to your students. And you can give them reading materials. Ebooks are also a good source. Open education sources are available. Seminars, labs, experience. All these things are the strategies for engaging your learner with the content. Then when it comes to the communication with their fellow students or other, I mean with their faculty, there are also other tools available like discussion boards, online rooms, emails. So people who are using Google Meet, Zoom and other platforms, they can have breakout rooms, and you can even communicate with your learner through email, mobile, WhatsApp, Skype, blogs, Twitter. All these can be used for this thing. It's not that only you have to engage them inside the classroom, even outside the classroom also you can. It's not that only during the session you have to engage your learners. Even before starting the session also, you can start your engagement. And it doesn't mean that once this physical session is over or the online session is over, our engagement stops. Even after that also, you can give post-session activities. So always the engagement is ubiquitous. It is before the session, during the session, and after the session also. So these are some of the tools which will help faculty to use all these tools in an effective way so that you can effectively engage your learners. Then the third one is the collaboration peers, where you can have the wiki pages, blogs, peer review, group projects, discussion. So this is you are taking your learner to the reflective level. The first one is you are taking your learner to the memory level. The second one helps them to reach the understanding level. And the third one, when they collaborate, they reach the reflective level. So as I said, that when they reach the reflective level, they become creators, they become analyzers, they become problem solvers. So all these things can happen when you give an opportunity for them, when you allow them to collaborate with teachers and other peers. So these are some of the engagement strategies you can note down. And what are the factors that influence your student engagement in remote learning? So there are four major factors. There are a lot of other factors. Here I have mentioned only four major factors, that too with reference to the human needs. One of the factor is the success. Suppose if your learner finds, okay, the learning strategy that you use, the online strategy or the offline strategy, whatever it is, whatever you used for your learner is yields them the expected result, they will get the feel of success, and again they will look forward for such kind of learning experience. So success is one indicator, one factor. Then the curiosity. So it is left up to the teacher, the resources he uses, the way he motivates his students, so that the student shows more, so students become more curious, more and more curious, and look forward for the teacher session or look forward for more and more content for further learning. And the originality, if you give opportunity for the learners to think on their own, lot of ideas are generated by the learner, and that makes them to feel satisfied, that makes them to gain more confidence on them, and that will give them more self-expression. So they feel, okay, if I go to this class, I'll get an opportunity to self-express myself, I'll get more opportunity to introspect myself, I'll get more opportunity to express my ideas, I'll get more opportunity to generate more ideas, invent and then innovate. So he feels more confident. So that is also one of the factors to engage your remote learners. Then relationships. So the way you involve your learners with yourself, the way you connect with your learners, and the way you allow them to connect your learners with others, also encourage them to take part in the remote learning. So that connection should be meaningful connection, maybe in the form of a group discussion. Say, for example, the strategies like think, pair, share, roundtable brainstorming, circular questioning. All these things will what help them to form team, help them to compete with others, create healthy competition among the learners. So all these things can happen only if the teacher provides opportunity for establishing healthy relationships with the teacher and healthy connection with other learners. So when you say you are engaging your learners, you can very well easily identify the engaged learners and the disengaged learners. When you say your learners are engaged, there are a lot of indicators to say that our learners are engaged. One is the willingness to participate. If your learners come forward to take part in your learning session, that shows they are engaged. They have started engaging themselves and they assist others for learning. They involve frequently. If they start creating something, you give them a task of creating a PowerPoint video or something like. If they involve themselves, they are engaged learners. They give you some answers when you question. They are more interactive during the classrooms. Initiate something, contribute something, and organize the learning content in an organized way, and then present it in before others. And so if you see all these behaviors, they are all called as indicators for engaged learner. The opposite of all these are the disengaged learners. Suppose if your learner is said to be engaged, if he shows willingness to participate, the disengaged learner will not show willingness to participate. If he's involved, if some learners come forward to involve in the process of learning, the disengaged learner will not involve. He will avoid, he will skip, he will postpone. Disengaged learners will not answer, disengaged learners will not involve in the problem solving activities. So all these things are called as what? Indicators to say that the learners are disengaged. So engaged versus disengaged. When you will be able to figure out all these things, only if you have more and more, formats for delivery. As I earlier said, pluralized content, pluralized delivery, pluralization of the content. So the same content in different formats will help you to identify whether your learner is engaged or not. Then the next thing is adult learning principles. So how to use adult learning principles in for learner engagement. This slide shows if you make your learners to feel it is goal oriented, they'll definitely become. So you have to tell this is the aim of the session, goal of the session, why they should learn, how they should learn. If they learn, you have to ask them how did they learn that particular topic. They will come out and say, so if there are 50 participants in a classroom, students in a classroom, you ask them, you take a content and then deliver it appropriately using the selected teaching learning method. Finally, ask the student, how are you going to learn? 50 students will give 50 ideas for learning that. So that is how you have to bring in relevance for learning, provide opportunity for the learners. So goal-oriented, practical, self-directed, task-oriented, experience, relevant. So all these are the nature of adult learners, and that will promote, that will help the teacher to use the intrinsic motivation of the learner. So because learners come with a lot of ideas, a lot of motivation inside the classroom, but after listening to the classroom, their motivation comes down sometimes, or they are not, they don't sustain their interest in the session. It is because that they are not engaged properly. So if we give more, if the session is more problem centered, again it becomes more engaging for the learners. So these are some of the adult learning principles that will help us to make our learner engage in a more meaningful way. So this slide shows that learners engagement should be, so when to start learner? Initially, teachers see most of the time it is only supply based. If you go to any college, not only in medical education, in any higher education, if you see it is only supply based. The content is given, the unit is given in the syllabus, and this is the content. I have to finish in 1 month or 1 week time this one. So last night I prepared. So today morning I'm presenting it. So this is why. So it is supply based. Since I prepared, I learned, and I prepared this resource. It is supply based. Whether the student want this or not, we don't bother. So that is called a supply based. But initially our classes should be supply based, so that you can bring the learners on track. And finally, when due course of time, it should be on demand based. What is this demand based? You can only take the little of the content. Much of the content should, this learner should come and ask you, sir, how to learn this one, how to work with this one, how to solve this problem. Can you arrange a session on that? That is called as demand based. So if you have a content in your hand, don't transact all the content in your own style. only just teach the fundamentals of the content. Rest of the thing, you see that your students come and demand you in one way or other. So address the learning needs. So you have to address the learning needs if you think that. So you address the what is this learning needs. Identify the learning needs of the learner. You will get many types of learners in a classroom. First of all, you should know who your learners are. What do they want to learn, and how they wanted to learn. So if you just make a small study of this thing, it's a small action research in your class, and you can easily address their learning needs. Then foster further learning. So your teaching should help them to what? Look for the other level of learning, which is called as the further learning. So initially you start with guided learning, go with the walk with the learner, then you direct them, instruct them. Okay, this is topic, learn this topic like this. That is called the directed self-learning. Then you tell them, okay, you choose this topic. This is the topic. You choose your method of learning. That is self-directed learning. Then both the topic and method of learning will be chosen by the learner. That is self-determined learning. So guided learning is fully guided by the teacher. That is, the teacher walks with the learner. Directed self-learning is the teacher chooses the content and the method for learning. And in self-directed learning, the teacher only suggests the content. The method of learning is decided by the learner. And self-determined learning, both the content and method is decided by the learner. Say, for example, the Coursera courses, the MOOCs courses are all self-determined by the learner. So nobody is going to prevent the students to choose and learn such courses. So more intimate and engaging thing. So you should also, when you want to engage, your engagement should be intimate and then engaging for the learners, and take into consideration of adult teaching learning principles, and take into consideration, so social distancing should not be a problem, and it should not lead to social isolation. So thinking that we are all using these online platform and other things, remote learning, so everything, don't think so. In the name of remote learning, you don't social distance and then make your learner self-isolated. So social distancing is only for COVID and not for education. And so this social distancing should not lead to self-isolation. I hope you understand this point. So this is again one more thing which as a teacher we should know. Now we know that the content is already there. As you know that medical content is voluminous, and a medical student has to master enormous amount of knowledge to become a doctor or a PG or whatever it is. So the content is already there. And as a teacher, we also know some pedagogy, how to convert this content into pedagogy, the lesson plan and how to deliver it. And that is the pedagogy, the art and science of teaching that content. And technology is enough. Technology is there. Suppose if you look at the things, there is now the technology outnumber the content. So there are a lot of technologies available, but there are no much takers for the technology, because much of the technology is not known to the teachers, or they are not aware of it. Even if it is aware, even if they are aware, they don't come forward to use the technology. Now, why this slide is very important? So as I said, there are three components, three circles here. One is the content, the other one is the pedagogy. The third one is the technology. So as a teacher, first you make connection with the content, as I already said. Then it becomes pedagogical content knowledge. A teacher should be familiar with three different knowledges. That is four different knowledges, which is called as, the first knowledge is the pedagogical content knowledge. This is pedagogical knowledge, knowledge of content, knowledge of technology, separate entity. Okay, now this pedagogical knowledge is combined with the content knowledge. Okay, the content knowledge is combined with the pedagogy, which you call it as the pedagogical content knowledge. Pedagogical content knowledge. Now you know the pedagogy, the teaching technology, and teaching learning techniques, and you are going to combine this teaching pedagogy with the technology, which is called as the pedagogical technology knowledge. Knowledge of pedagogy and technology, or techno-pedagogical knowledge. So pedagogical content knowledge, techno-pedagogical knowledge, then, and you are going to convert this content into different formats: video, audio, podcast, videocast, discussion forum, all these things with the help of technology. Then it becomes techno-content knowledge. So techno-content knowledge, techno-pedagogy knowledge, and pedagogical content knowledge. So three different knowledge. When you combine all these four, you get techno-pedagogical content knowledge, TPAC. So technological knowledge, content knowledge, pedagogical knowledge, pedagogy and content, pedagogical content knowledge, then content and technology, technology content knowledge, then pedagogy and technology, techno-pedagogical knowledge. And when you combine all these three things, you get techno-pedagogical content knowledge. Why this techno-pedagogical content knowledge is important for medical teachers? Because now we have content, we know the teaching learning methods, but if you don't appropriately mix technology with content and the pedagogy, definitely we cannot engage the present generation children. I mean, learners, because the current generation learners are the tech-savvy people, and they are called as the Z generation or Y generation, whatever generation you say. So they are all tech-savvy people. They are well informed, and they technology may be a luxurious item for us as teachers. For us, it may be luxury, but it is part and parcel of their life. So we have to master this techno-pedagogical content knowledge. Then only we can identify appropriate content, apply it to the technology, and then deliver it accordingly. So please browse and see more about this particular information in Google. So, so how to plan for effective engagement of learner? Always you keep a lesson plan, which should include the objectives and plan activities for pre-session, before the session, during the session, post-session, and apply the principles of pedagogy, andragogy, and pedagogy. And because why I'm mentioning this is sometimes we only use pedagogy, sometimes we overuse andragogy, sometimes we don't use none of this, and we think our learners can learn on themselves, which is called as pedagogy. Okay, so that should not happen. So appropriately mix all these learning principles or learning theories and learning engagement domain. See that always you engage your learners with their heart, head, hand. All these three things should be engaged appropriately. That is cognitive, emotional, and behavioral. And learning theories, take the support of the learning theories and see which kind of learning theory you are more using, so that your learners will become that sort of. So it is not that you have to use only cognitism, only behaviorism. It should be an eclectic approach. It should be a blend mixture of all these theories. So you can check your lesson plan whether your lesson plan addresses all these things, and it should generate learning evidence. Don't say, if you say you have taught your learners should have learned something. So what is the evidence for that? Behavioral modification. If you say that your behavior is modified, how are you going to assess? So appropriate assessment method is needed. And if you say that you have done the assessment, that means you are producing evidence for learning. So this is how you have to generate evidence. Whatever activity you give, see that a learning evidence is created and it goes into the portfolio of the student. That makes the learner more and more engaged. So provision for correction, reinforcement, and feedback should always be there. On the spot, you do the correction whenever they go a mistake, or you reinforce them when they do something correctly. You give them positive reinforce. When they do something wrongly, you just give them negative reinforcement, and finally you give them feedback for their improvement. And of course, assessment will also help you to identify their strengths and weakness, and help them to identify the avenues for further learning. Now, this is the grid for the lesson plan. So this will be very helpful for you. Here I have mentioned the competencies, and the competencies will be broken according to our competency-based medical education. You break the competencies into objectives, addressing all the three domains, that is knowledge, attitude, and skills. And the learning principles which you are going to apply here, or the engagement principle, whether it is behavioral or cognitive or relational or behavioral, what kind of principle you are going to use, that also you just make a note. And then which theory it is mostly dependent on, and what are the activities you are going to give to your students, that is whether it is reading or writing, think, discuss, resolve, solve, analyze, create. All these things are part of this lesson plan. This will give you an idea about the content. Once you keep the content here, fit your content into this, then only you will see, oh, my content has this much opportunity for my students to be delivered. So if you don't fit your content, at least if you try to fit your content into all these things, then you'll see even a small content can be delivered in a very effective manner. So assessment and then feedback. So that is the purpose of this grid. So this lesson plan will help you to what? Bifurcate your content, split your content, so that the learning, your teaching becomes more effective and learning becomes more meaningful. So methods and tools for active learning, this is at a glance I will tell you. So for reading, listening, reading, writing, discussing, solve, create, evaluate, judge, reason, you have tools. So identify tools according to this. So online lecture, you have these tools: Zoom, Google Meet, Microsoft Team. And for online quiz, opinion polls, for conducting opinion polls, there are tools like Voxvote and Poll Everywhere. Poll Everywhere can be embedded into your PowerPoint, and Voxvote can be used for conducting opinion polls. And online test by using the softwares like TestMouse, Google Forms, Class Markers can be used for conducting online tests. For e-assignments, you can use Google Classroom and Canvas. And discussion forum, use email, Google groups, etc., etc. And for collaborative writing, you have a tool. I mean, Google Docs is a very wonderful tool for collaborate. On the spot, you can make your learners to contribute, and within 1 hour, you can create any. You can generate as much knowledge as possible, or within 10 minutes. Okay, so you can see who is contributing, who is editing. All these things can be seen through Google Docs. And reading exercises by you can give reading exercise by referring some ebooks. Podcasts are there for listening exercise. Watch and learn can be done by using watch and learn exercise by using YouTube and other video sources. And virtual learning environment like virtual labs are there. Some Western universities have established very good virtual labs. Most of these things are freely available. Harvard University's virtual lab is freely available. You can learn to enter into a lab. You can take some tasks. You can do some laboratory activities, assess yourself. So digital case scenario, students as teachers and creators, identify some students and then use them for creating resources, identify some students and then interest them the job of teaching other students, introduce e-portfolio. So all these things will make, these are only short list. What you are seeing is only the minimum of things. There are also n number of activities. You can also improvise your own method of delivery. Making your learners actively engaged in the process. Okay, so that is one thing. So usually whenever I take such sessions, about online teaching technology, people have some frequently asked questions, whether e-learning in higher education, are we compromising with traditional education system or formal education? So e-learning, though it is not formal education, when you say formal education, you need to have a stipulated age, qualification, entry behavior, exit behavior, and all those things are there. And that attendance is a must. So all these things are part of the punctuality, regularity, all those things are part of formal education. But still, e-learning can also be made as formal education. But the current curriculum is not designed for e-delivery, because that is again one more question again I used to get frequently from my participants. So current curriculum is not designed for e-delivery, that is for e-learning, but it can be converted for it can be designed for e-learning. So as a teacher, you have to see how this competency-based medical education can be effectively converted for e-delivery or e-mode of presentation. Then moving towards the de-schooling society. Suppose if this online thing, almost it is success now. So any course can be conducted online, any course, except the attitude part. People are telling that the skill part is little. Even now, still, there are a lot of scope that even the skill part and the attitude part can be very well met by the online education. So there is a school called, there is a school of thought called as de-schooling society, which says that remove all the schools and colleges, give freedom for the learners to choose their own courses and then learn. So the days are not, too far. Maybe it may happen in 1 or 2 decades also, because many, as I told you, now all these libraries are being slowly replaced with e-learning centers, or they are all used for some other purpose. We don't require infrastructure to conduct a school or a college. And thanks to COVID for making us to realize this situation. And the role of human element in online delivery. So how we affect, now only you have to think. You may feel no. So in that case, what is the role of teacher? Whether the teacher has an effective role or not. Now only the teacher has an effective role. So no one can substitute a teacher. You demolish the school, demolish all the classrooms, demolish library, everything you bring online. But without that human element, you cannot teach your students, because it is the human element that makes the course, effective. Why? Because now when we are capable of creating smart apps and smart educational applications, so who is creating all these? It is the human element that is creating. That means we are born to outsmart this technology. So we have to what? We should try to become smart teachers so that this technology can be effectively used by by the teachers. That is the point you should note here. So the role of a human element in online teaching is that teachers should be more smarter than the technology they are using. Right. So these are some of the, how do I know my students are engaged in online, they are actively engaged in online thing. These are the indicators. So observational learning behavior, it can be classified into two groups, two categories. One is observational learning behavior, which includes reading emails, reading discussion posts, viewing videos, lecturing, documents, continuous. All these things are indicators to say my learner is behavior. It is an observational behavior, a learning behavior. And whether he is applying the knowledge he is using, what he learned in the online thing during his engagement, these are the indicators. to say that the learner is applying. That is includes posting to the forums, writing reply mails, taking online quizzes and other tests. So all these are giving feedback, receive feedback, post self-created roses. These are all the indicators to say that the learner has started applying this thing. Then finally, evidence for meaningful learning may also be established by doing a systematic interaction analysis. So whenever you finish your class, see, do an interaction. How many students interacted? What did they interact? How did they interact? For what they interacted? What is the outcome of that interaction? So whether how many right answers you got, how many wrong answers you got, how many students were actively involved, so how much time was spent on this, all these big data will help you to say, which is called as interaction analysis, which you call it as big data. Normally, we call big data as the pass mark and the student age and the number of students, but they are all the small data. But the big data is sort of really a hidden data that is hidden in our classrooms. So when you look at all these things, you can really make use of such data to, through interaction analysis and make your teaching learning more effective and more engaging. So engaging the teacher learning participation, how to engage teacher and learner by incentivizing them for their achievements and reward the students. You can use, say, Kahoot is a software where gamification is there. So if the learner comes top, it gives trophies, it gives sweets, it gives claps, people clap. So all these things gamifying, they give badge star and other badges are given, trophies are given, certificates. So like that, you can encourage the participation by incentivizing or by rewarding the learners as well as the teachers. So providing timely constructive feedback, adding self-assessment rubrics, all these things will enhance the participation of both the teacher and the learner. So to conclude, I would say that appropriate learner and engagement strategies will help our learners to continuously involve themselves in the learning process and will also foster good study. That is more important. So it's not what you are going to teach, how you teach is more important, and your teaching should foster good learning habit, and it should make your learners a continuous learner, lifelong learner. And all these require faculty involvement. So you have to, as a faculty, we have to train ourselves, equip ourselves, improve our skills on identifying the appropriate digital learning platforms, designing educational activities, and through proper planning. So then only we can effectively engage our learners. Then finally, though technology cannot fully substitute a good teaching or a teacher, it can be used as an effective tool for actively engaging the learner. So technology cannot substitute a teacher. Again, I would like to reinforce that. So only technology is another tool. That's all. So I'll be happy to take any questions.
Thank you, sir. Your topic was exactly matching with your talk was exactly matching with your topic, engaging all the learners on the other side of the system. And thanks
Thank
for
you.
emphasizing on creating the connection between the content, teacher, and the learner, and also the connection between content, pedagogy, and technology knowledge. And we should move on to demand-based teaching than driven-based teaching. Thanks a lot for emphasizing everything, sir. There are a couple of questions for you. How to
Sure.
assist students in remote learning? Any effective platform available that
Yeah,
prevents
there are
malpractice?
yes, there are a lot of platforms available. I would suggest there is a very vast site, website available. One popular site which is called as Go Formative. Please browse and see Go Formative site. You have all kinds of assessment. See the tool I mentioned here, the poll everywhere, Voxvote, all these things are tools which can be used for online assessment. TestMoz is another very easy tool. Google Forms can be used. There are a lot of tools. But if you go to just browse and see the website Go Formative, it gives a variety of tools for online assessment, especially for the remote learners.
How often one can pluralize the content, as each mode of delivering content would have some advantage over the other?
Yeah, see, this is a good question. Actually, we cannot, if you ask me how often, you can say very often you have to pluralize because the technological advancements are there. So once PowerPoint was the only technology. So before that, the OHP was the only technology. So before that, we were using the chalk and talk method. Now, the same PowerPoint, you have a lot of technology inside. How many of us are using the voiceover with the PowerPoint? There is a technology, lot of options are available in the technology. So same PowerPoint, you can include video. Similarly, there are also other forms of content, say video casts are there, podcasts are there. So if you think of how often, very often a teacher, but it all depends on the context and the group of learners you have. Suppose your learners are more and more demanding, you can pluralize more and more. Suppose as you started saying that whether it is frequently, is it good to frequently pluralize our content? No, I would say. So first go with the frequent content, test it with your learners, see whether how is the reception among your learner. Then you can decide on the other formats of the content. So this is how we have. So this will not happen immediately. So it will take out of experience only a teacher can design all these things, develop all these formats.
One last question. Can you please throw some light on rubrics?
Sorry?
Rubric, R-U-B-R-I-C.
Rubrics, yeah.
Rubrics.
So rubrics are it's a kind of assessment tool where you give a task and then you ask your learners, you split the task into different formats, and then you ask whether they have learned or not, if they have learned, to what extent they have learned, and what kind of behavior modification. So according to your needs. So as a teacher, you can make a rubric into different behavioral terms. So the outcomes should be measured in terms of behavioral terms. Okay, it can be in the form of knowledge. If you want to assess knowledge, also you can assess. If you want to assess the attitude, also you can assess. And if you want to ask their reflection about the skill they learned, that can also. So it is the component, the elements in the rubrics are all given in the form of behavioral terms. As a teacher, if I want to know whether any behavior modification has taken place in my learner or not, and I have to say what kind of behavioral modification I expect from my learner, that should be made into a statement and ask my learner. If my learner says, okay, yes, not, or borderline, or to some extent, or not at all, then it is.
Thank you, sir. I would like to share a certificate from organizing committee for
Thank you.
accepting as a speaker in our conference. Thanks a lot.
So I take this opportunity to thank the main organizers of SRM Medical College Hospital and Research Center, Dr. Lokaraj and Dr. Balaji, who is the compare for this session, anchor for this session, and all the other organizers for meticulously organizing this program. Thank you very much. And once again, thanks for the opportunity. All the best.
Thank you, sir. Thank you.
Can I sign out?
Yes, sir.
Yeah, thank you.
So we will move on to the next scientific session. In fact, I'm very glad to introduce Dr. Sitaraman sir, with whom I worked for a year or two, and very nice person. I will share some credentials about sir. Dr. Sitaraman is a professor and head of the Department of Community Medicine, Kovai Medical College Hospital Institute of Health Sciences and Research, Coimbatore. Sir has designed and implemented community-based learning modules for different phases of MBBS. His areas of interest include application of IT tools in healthcare, spatial epidemiology, medical education, and research methodology training. He has worked in various projects on GIS and tuberculosis control, transgenders, social media influencers, stray dog, RTAs, and e-waste disposal. He has keen slant towards inculcating research aptitude among students. He has about 20 plus national and international publications to his credit. And he's going to present on the electives in undergraduate medical education, an area to be explored. Over to you, sir.
Thank you, Dr. Balaji. Am I audible?
Yes, you're audible.
Okay.
It's visible.
Good afternoon, all. Greetings from Coimbatore. I am Dr. Sitaraman. This session, we will try to take a look at electives and the opportunities and challenges that we expect with this newly introduced initiative. I find this as an exciting new initiative among all those within CBME. Electives is kind of exciting, right? Like foundation course, it gives you a freedom to do something not very restrictive. The MCA has given the broad outline. It's up to us to design our own program. So we are looking forward to do this. Okay, I guess my primary objective for the session is to keep the, how many? 140. We have 140 participants. I guess the primary objective is to keep you engaged, like Dr. Jayaprakasham sir said, to leave, is to keep you from getting disengaged, getting sleepy. So all these flashy colors are one way of keeping you engaged. Right then. So session overview, what we are going to see is, what are these electives, when do we do this, where do we do this, and a little bit on why has this been introduced, also on how are we going to do this, and if you guys speak up, we can look at some of the challenges and opportunities that we expect to see, and there will be a summary, what to do when you go back section, right? So I'll assume that uh, a basic recap is needed. And it's probably not needed for everybody because you all have attended varying degrees of medical education courses, but still for uniformity, I'll have to talk to a kind of homogeneous audience. So what are electives? It's a brief course made available to the learner during their undergraduate period, where they can choose from available options depending upon their interest and career preferences. Right. So when is this placed? It's placed right after part 1 exams, that is third MBBS part 1 exams, before they enter into third MBBS part 2, before students get into final year. So if you have been wondering, this 2 months is part of the time that was taken from second MBBS. What used to be 15 months became 11 months. You are familiar with that, right? So this 2 months is from there. So we at least owe this much, that make these 2 months as useful as possible, right? Okay. So now why? Now, why is a big question usually. If we get convinced about the usefulness of not just this program, any initiative, then the rest will fall in place. So getting convinced that yes, this is useful, that is that's what is answered by the question why here. Now, if you ask me, if I'm not looking at the MCA's booklet on this, I would say the why is because if you take a step back and look how we choose our post graduation, whether it's really informed choice, do we make it as an informed choice? Means I will be little hesitant to answer that. So most of the choices of post graduation are made as soft choices. We don't really have a hands-on experience of how each field is going to be. We look at people who are in that and we take a guess, probably an educated guess as to okay, this is how it will be. Um, I don't think that qualifies as a informed choice. So towards that, having electives is one of the ways to make our post-graduation choice and a career choice an informed one. It gives you a taste of how a field is going to be. Okay, let's see what MCA has to say about this. The objective is to provide the learner with the opportunities for diverse learning experiences and opportunities for research and community projects that will stimulate inquiry, self-directed and experiential learning, and lateral thinking. And these are the stated objectives, and the intent is to allow flexibility and choice during study period. They can look back at things without the, let me say, fear of an exam. They can look beyond examinations when they are part of electives. They are looking beyond examinations. This is the part I was saying earlier. Provide an opportunity to explore areas of interest that can supplement future studies. They can have a direct hands-on experience of working in their areas of interest. And it will develop self-directed learning skills. They will also develop a fair bit of critical thinking because they reflect and learn. Right. And of course, this will count as a very nice student-centric approach within CBME. That is about the why of CBME, why of electives. Now, where do we do this? Where exactly does this happen in the sense? The broadest of guidelines is that it has to be directly or indirectly connected with healthcare. I mean, that gives us a lot of scope. So it can happen in specialty or super specialty clinical electives. It can happen as an educational electives in the first second MBBS subjects. It can also happen as laboratory electives. It can be community-based electives, or it can also be research projects. So that's quite a wide variety of choices we have. Right. One thing we need to remember is it is not an extension of usual postings, meaning um, it might have two meanings. One is we don't post them to the usual postings that we do, usually, right? The other meaning is even if we post them to the same, same departments or so, the thrust or the objective of the posting will be different. It will not be seeing more cases. It will not be, being exam ready. The objectives will be different, even if you post them in the same, clinics or wards or OPs. So these are not more of our clinical postings. This is something different. Right. Now, this is a sample list. This, if we are kind of feeling that we need a list, they have given this list, but there is no need to stick to this list. We can think beyond this list. Uh, a list of possible postings in block 1 and block 2. Now, I'll come back to that. There are 2 blocks. So, right. So, you can read this little later when you have post session, right? So these 2 blocks are 4 weeks each. Each of these block is 4 weeks, and the block 1, the purpose is to provide learner with research experiences in basic sciences or laboratory sciences or research experience in the clinical sciences, right? So block 2 is to provide patient care, uh, rather a guided experience in a patient care setting, right? So the common ones both are 2 weeks, 4 weeks each, and both happen before commencement of third MBS part 2. And the focus changes. If you see here, focus of block 1 is to in one of these laboratories or joining an ongoing research program, whereas focus of block 2 is clinical specialties or community clinics. The nature of learning is same in both. It's supervised, experiential, immersive, and self-directed learning. So this is something that you might be interested when you're planning your curriculum. The regular clinical postings will continue in block 1. Those 4 weeks, regular clinical postings will continue, which means here final year clinical postings. Now, during the second month, that is block 2, there will not be any other clinical posting. It will be a full-time elective posting. So you may want to plan your curriculum accordingly, curricular time accordingly. Both have attendance and assessments are similar. 75% attendance is needed. That is a prerequisite to be allowed to take part the final year exam. We will have formative assessment in both. Logbook entries and portfolios are needed for both. And the last 2 is about where they can do this. Can they go out of the institute? Can they go out of the state? There's minor differences in this. Right now, if we look at the fine prints, number 1 is it is compulsory. Nobody can skip this. All your students have to take one of the electives. I mean, it sounds kind of funny. It's a compulsory elective, right? So they have to take one. Which one they take is up to their choice. And this is a protected time. This is not for making up of missed clinical postings or shortage of attendance or any other purpose. This is only meant to be used for elective postings. Now, being a new initiative, institutions as well as the faculty in the institutions need to be trained on how to go about this. And we need somebody called a preceptor. This is like another new word for a guide or a mentor. So a preceptor to guide, monitor, and assess students throughout these 4 weeks of posting. That is needed. And admission, attendance and logbooks are needed, like we just saw. And this was also seen. If resources are available, students may be permitted to do electives in other medical colleges or institute. So this sentence is from the first version of the document, which said even outside the country. The second version kind of toned it down, and this word is missing from the second version, the latest version. But anyway, you can do outside your institute, outside your state also definitely you can do with permission of the local authorities. Now, outside the country part, I'm little doubtful. Right. Now, if you look at this, I think these should be the steps. First should be, we should sit down and identify what are all the possible electives, one within and two outside the institution. And we should work on these. We should finalize the number of electives. How many choices am I going to give from which students can pick? In the nature of electives, how it will be done. And then each elective might be able to hold only a certain number of students for effective learning. So we need to specify how many maximum a particular elective can hold. And then we need to identify and sensitize and finalize these preceptors who will be taking care of the students during the posting hours. Right. And then this is probably, from a pedagogical point of view, this is probably the most important. All these electives should have learning objectives. We cannot be a 4-week tour program. We need to have specific learning objectives. At the end of this posting, the learner would achieve this. We need to have educational outcomes, and we also need to sit and figure out how we are going to assess the students. All these things should be developed before we can think of sending students to electives. All these details should be made available to the students in advance. I think in advance is key here, because once they choose, we need time to plan accordingly. So at one place in the document it says at the beginning of assessment year it's desirable. Another place it is said at least 3 months before the actual start. So either way, the list of electives, what they are expected to learn there, and what they are expected to bring to the table, all those should be specified, made available to the student, and then they should also make the choice fairly earlier so that we can plan and proceed further. Right. So prerequisites, what they should come ready with, and what will be available as learning resources during each elective. And define formative assessments and portfolio and logbook requirements. All these should be conveyed to the students also. And I think this program evaluation plan, looking from a program manager point of view, I think this will be the important one. The first assessment is about assessing the students. This is about assessing our program, how well the program went, what were the what could be improved, what could be done differently next time. So that should also be built into our plan, so that we can improve the next time. Right. So this is a sample template which has a lot of necessary information. Think of it like a lesson plan for your lessons. Once you finish this, then you're good to go. You can be confident that yes, I can do this. So it says name of the block, which elective is this, name of the elective, where is it in a hospital or a lab or a research facility, who's the internal preceptor, is there any external preceptor, what is the learning objective, number of students, prerequisite, learning resources, activities which the student will participate, portfolio entries required, assessment, other comments. Now, if you see a filled one, you will understand more. It's difficult to fit a lot of things into one slide. The next slide might be a little difficult to read, but we'll see. Right, so this one, sample template, diabetology clinic, right? So this is in block 2, the second set of rotation. If a student chooses a diabetology elective, he'll be in the medical college hospital, and names will be filled. The learning objectives will be 1, 2, 3, 4 objectives we have laid down. And prerequisite is that you should have received necessary immunizations, basic life support training. Okay, not too much strain on the student also, but then some prerequisite is always needed. And the learning resource is a book by Krishna Sheshatri, and then list of activities which the student is expected to participate in. That also we are essentially defining the scope of the program, what he will be expected to do. So he will be participating in rounds, afternoon teaching sessions. He will be presenting at least 2 cases, in patient education meetings, participate in audit meetings. So we are telling him the depth of his involvement essentially. That is what we are doing by developing this sample template. So however many electives you are planning, each elective needs a sheet like this. Okay. Right. Now, this section I would like to hear from you, because the previous ones they are in the booklet. You can also read those, but these it will be good if we make it a discussion. So I would love to hear from you either in an audio way or a chat box type. What do you think would be the challenges in implementing such an electives program? Can I hear from you guys? Can I
They
see
can only
somebody
read the
typing
chat,
something?
sir. Yeah, they can only
Okay,
chat.
can we see a chat? How do I see the chat window? Okay, I see it.
We have got one.
Balaji, in case if I miss something, can you read it
I
out
will.
for me?
I will read. How
Okay,
to accommodate all the two students 250 in a batch.
right. Okay, 250 is divided into as many as we want. It will depend on, yeah, first of all, 250 is a big number. We'll start from there. Uh, the next will be to have as many elective choices as possible. If you divide them into, let's say, 25 electives across your hospital, your college, and your health centers, then that becomes only 10 per elective, right? So if you have more number of students, plan more choices. You can have, you can think out of the box really here. You can have, for example, um, master health checkup postings. You can have MRD postings. I'm just thinking out loud here. So basically, how to manage more number of students is to have more number of elective choices, so that the effective numbers in each elective becomes less. I hope that makes sense.
One challenge is many students asking for the same elective. That's a
Very
good.
nice. Yes. Yes, yes, this is to be expected. Some electives may be high demand electives, some electives may be low demand. So, if elective A can only accommodate 10 people and 50 students are applying for that, what do we do? I actually don't have a ready-made answer for that. Only thing is we cannot have more than 10. That much I can say. But how exactly do we, send them to another posting? One clue is the word that is given in the document. It says students counseling sessions, meaning we have to kind of counsel them, and it has two purposes. This counseling has two purposes. One is, are they putting it out of their own interest? We will be sitting with the choices the students have made and we'll be counseling them. So the first purpose is to see whether they have actually picked these choices out of their own interest, or because their friend made the choice, I also tick the same thing. Those kind of things we'll be evaluating. And the next is about the accommodating point. Can we accommodate all of these people? If we are not able to accommodate, we will have to kind of cajole them, I guess, into some other um, electives. I don't see any other way. We cannot exceed the let's say if your simulation center says I can only accommodate 12, we cannot dump 20 people there. That's going to spoil your learning experiences. So we'll have to work out a way. That's part of the beauty of electives. We have not done this. Yeah, the beauty is that we are allowed to explore and share our experiences. So next year around, when we have the same thing, we may have better answers. But right now, this much only I also know, guys. Okay.
Is there any assessment for elective?
Yes, we
Period
need to build
assessment.
assessments. Yes, we need to assess. We need to assess. It will be formative assessment, but definitely yes, we need to assess. We um, we need to assess. One sec, let me see if there is anything with regard to assessment here. Yeah, it says here in this last line, it is formative assessment. It, for example, this can be participation in OP and IP rounds. How many days he has participated? The attendance itself can be part of an assessment. Team activities is he participating, and then presentation of worked up cases, documentation, does he fill his portfolio? All these can add up as small chunks of assessment and give you an overall score if you want, but it is a formative assessment. Okay.
One message is students may have lesser in-depth knowledge on scopes of different elective topics.
Yes, agreed. I mean, um, they will definitely acquire more knowledge if they're with us for 6 months. Agreed, but then it has to be built within the MBBS course, right? Look at it this way. I agree with what you're saying, but just in place of nothing, I think 4 weeks of posting serves the purpose. Before we didn't have anything like this. No, now at least we have a 4 week taste of how the field is going to be. That's how that's the right way to look at it, I think.
Yes, sir. And some are suggestions saying it can be selected based on their university marks, metrics, or some tests can be conducted to decide which
Nice.
posting they can take.
Okay, that's very nice. That's like really peer learning here. You are answering some of your friends' questions. How do we go about selecting who gets, like the previous example? If 50 students are competing for 10 elective, seats, so to speak, which 10 do we give? Yes, then we can probably look at their marks and yeah, I hope you get the point. But like I said before, this is part of the appeal for me that it has not been done before. There are going to be 15 different ways of doing any given thing. And sometime later, next year, after we finish this, we can have a very nice experience sharing. The good experiences can be, copied by other institutes. Don't feel shy to what do I say, to propagate your way of doing things. See, somebody used to say copying is the best form of flattery. So if your model is being copied in another institute, feel good about it. Don't hoard your methods. Please share it so that let them copy. Let them copy. Uh, so you will at least know that, okay, this is my model. It's worth doing. So that is why it is being replicated elsewhere. Right. So I think that's enough challenges. We can
Yeah,
look at the chat box a little later. I will send, if I find some other interesting questions, I will send the answers in the chat box. The next is, okay, so basically most of our challenges will fall under these broad headings. It may arise because we have inadequate training, and it might be because it's, starting trouble. It's the first time around, so it might be that. Basically, everything will come under perceptions, how we perceive, how much does the management view this as important, how much support they give. Everything can be brought under this one word called perceptions, how much importance is given to that. Right. So whatever our challenges is, they can be brought under these broad headings. Similarly, opportunities. Now, ideally, if this was a face-to-face session, we would have gone around the smaller groups in mic in hand and all. Anyways, this being a session, um, I think the first and foremost is the freedom we have to design our own thing. Like I said at the very beginning, they are given the broad picture, and we are supposed to paint it with our own brush. So each college is going to have a different looking elective program, which is the whole idea of what makes it exciting, right? So the freedom we have, it is not restrictive. It allows us to do what we can imagine. So this is what I said. You can showcase your model, your work to other institutes. You can present in platforms, and other people can learn from your work. And during this offering students postings outside and all, the institute may end up developing nice networking and linkages. We may get in touch with the neighboring institute, hospice or old age home, or the numbers are, the possibilities are limitless. Because students are asking for this, we may contact new organizations and institute, a nearby research institute, a nearby government lab testing institute, so many things. So we may end up benefiting from those, right? So there are a few things to think about. So I put it in this slide. Number one is this you have already asked, and some of you have even answered. How exactly are we going to allocate? Okay, we will tell the students that these are the choices, but how do they apply? Do we give them a application as to first choice, second choice, third choice, and then make them submit it to some place? Those suggestions have been made, but we need to work it out and see which works fine. Another is student safety, especially when posting them in outside places. We need to keep an eye on safety of our students. And there is this word comes quite a few times: student initiated elective, student initiated program, student initiated research, which means other than the list that we are making, we should also be open to student initiated, meaning this guy may come and say, sir, near my house there is an office which urban planning, for example, or something, there is a government fever clinic, it will be nice if we get posted there. If they bring such ideas, there should be a committee to look at it and kind of check the veracity of the claim, meaning, is it worth posting students for 4 weeks? Who can we contact there? So those also we should be uh, open for. It need not be outside the institute. Some student may say, I want to be posted in the records MRD department, which we didn't think of before. I'm just saying a possibility. So student initiated electives we should be open for. And then no, there is no talk of subunits so far. This whole 4 weeks should go as one block. That's what the document says. But maybe we might have a uh, revision. We may not. I don't know. But I'm sure some of you have thought of this. Can we have 2 postings within that 4 weeks? If we have thought about it, I don't have an answer, but I also thought about it. Should it be one or can it be two? As of now, it should be only one 4 weeks and then one more 4 weeks. Right. And then this is one sentence that you can make use of. What they're saying is part of the time may be used for strengthening basic skill certification. This word we should use for our benefit, for all parties' benefit. Although we cannot do postings and all in this time, we can still use this time if they're elective and certain basic skills uh, align themselves together, then we can use this time for certifying certain basic skills. I hope that makes sense. Right. So what do we do now? We have listened to somebody speak. I mean, that's me I'm talking about. You have attended the session. So what do we do going back? This is more like a take-home message. So you make working teams. Number one is you make one team which is responsible for all the planning, and then make few more teams, at least 2 more teams for the execution. One, you can activate the curriculum subcommittees for the phase 1, phase 2 curricular subcommittees. You can use them, and you can assign responsibilities to them. And then you sit and brainstorm, list out all those things, what we can offer, how many we can accommodate, uh, how will we assess, all those you do. And then you identify preceptors, people who are willing and people who are capable. And then this, please do not miss this, each elective needs learning objectives and educational outcomes, right? So all this and more are available in this MCA/NMC module. This is module 6 called electives. Most of what I've said are available here, except for your valuable discussions. Those are the ones that are not available, right? So I'm happy we discussed these. I can take some questions if you have. If not, we can. Okay,
Thank you,
then.
sir.
Right, Balaji.
Thank you for explaining and the guidelines given by MCI, and also how to take it forward, how to plan our elective session allotting for the students. And we have a question from one of the participants asking, how can a student approach other institutions outside state or country for elective?
Oh, no, no. Yeah. Student doesn't approach, sir. We have to approach. Student, if this is a student initiated research, if he tells that there is such and such course in Israel, I would like to attend that. It's just an example. If he says that, the institute has to, kind of contact them, and Israel was an extreme example, I guess, because that involves who will pay for money, who will take visa and all. But you generally get my drift, right? The student need not approach. He will bring us the possible ideas. We need to work out. The institute needs to work out the linkages and the mechanisms. We need to do. Student will be only the spark.
One more question. Electives like venture discovery are allowed, or they should be only strictly healthcare based?
Venture meaning like capital markets, share market, and the venture. What was it? Adventure. What was the meaning? I didn't get the meaning.
Okay, anything non-healthcare based, something that's how you should take it.
I don't
Should
think
it?
so. I don't think so. That can be done in the vacation time, not electives time.
I think that's all for the questions, sir. I would like to share the screen which has a certificate for you. Thanks for joining us and
Sweet
making
man.
this conference really special, sir. And this is your certificate for the same.
Thank you. It's been my pleasure. Okay.
Thank you, sir.
Thank you.
Thank you.
Yes, sir.
Bye bye.
Thank you, Sitaraman. Thank you, sir.
Thank you, sir.
Thank you.
Bye.
With this, we'll go to the last scientific session. And I would like to introduce the speaker.
Am I audible, sir?
Yes, ma'am. 1 second. I need to introduce you. So I welcome Dr. Kavita Rudhi Darwadkar. She's a professor and head in the Department of Biochemistry, People's College of Medical College and Research Center, Bhopal. She has completed advanced course in medical education from the Nodal Center, Kottayam, Kerala. She is a coordinator of medical education unit and is actively involved as a resource person and facilitator in various international institutional workshops. She has currently submitted a scholarly report and awaiting rewards of fellowship for a FAMA Philadelphia at the Regional Center, PSC Coimbatore. The title of our presentation is on feedback from all stakeholders and its analysis. Thank you for joining us, ma'am. Over to you.
Thank you, sir. May I share the screen, sir?
Yes, ma'am. I'll stop sharing. Yeah, you
Okay.
can.
Hearty good afternoon to each and everyone. And at the outset, let me thank Dr. Lograj sir and his team for a wonderful opportunity to be a speaker on this esteemed platform. So yes, I'll be speaking on feedback from stakeholders and its importance, as well as the analytical part, a little bit brushing up on that. And this feedback actually originated not from something else, but it originated from a rocket science. Yes, you heard it right. Because in the rocket science, the most integral control system is the feedback, which tells the machine how it is progressing towards its goal. So subsequently, the feedback became an integral part of many of the places to judge the progress of the performance, as well as to reiterate, as well as to rectify. So with this brief setup, I would like to have these objectives for today: to emphasize the role of feedback in CBME, to emphasize the stakeholders and the ways of feedback collection from these stakeholders, and to give feedback to students and receive the feedback from the students. So what is feedback? Now, you can see a small picture over there, I believe, in the corner, and I would like to draw your attention towards that. It's one of my favorite pictures whenever I take the sessions on feedback. So here is a rhino with its horn, and it is painting the landscapes. So from the picture, it is very apparent that the rhino is very happy with its implementation of painting, because it has painted quite a few sculptures, right? Quite a few landscapes. But what is the most common thing in all the landscapes? If you observe, there is a horn which is coming in all the pictures, right? So why is this horn? The reason is the rhino is not aware that the horn actually does not exist in the landscape, but it is its own part which is obscuring the view. So most of the times when we implement something, we always implement and assume that it is perfect and this is how it should be. But somebody needs to tell us where we falter, what we can do to improvise that. So feedback is defined as this piece of information about the performance or the behavior that leads to action to affirm or develop that particular performance or behavior. So what is the role of the feedback in CBME? So right in front of you, you have a cycle. This is called as the PDCA cycle. The ones who are in the lab setup would be more acquainted with this particular setup. And this is a integral part of total quality management. And since we are moving towards a competency-based medical education, the quality assurance or quality management also plays a very pivotal role, right? So it has 4 components: plan, do, check, and act. So what is this plan? So based on the felt needs and the need analysis, people felt that there was an urgent need for the curricular reforms, right? So that is how from traditional based learning, we started planning towards competency-based medical education. How did we feel that? Because IMG was not, Indian medical graduate was not globally relevant. So the curriculum designing started after the analysis. Then there was rampant training of all the faculties under faculty development program for ultimate implementation. Finally, in 2019-2020, we rolled out the CBME plan. That is our implementation, and we are almost 1 year through. So now, do we ask, did I do it right? Was there any hiccups? Were there any falters that we can rectify? Yes, that we have to do under our most important check state, where we have to evaluate, assess, and gather the effective implementation progress of how it is happening. And it is not possible that we are always correct. That's the reason it's called as a living document, right? So we might have faltered somewhere where the other institute might have done a better progress. So it has to be re-evaluated. When we do that, now we should act. We should act on the shortcomings, improvise it, then go back again to plan. So this cycle is evident that it is going to keep on happening. We plan, we do, we take a feedback and check. So it wouldn't be wrong if I say feedback happens to be the most important wheel of this cart called as competency-based medical education. So now that we have known that is quite important in CBME, so what are the types of feedback? Let me tell you that the feedback classification or typification of the key feedback is not rigid. Not one particular thing is solely active as its own. There could be combination of different types of feedback when we render it or we take it from our stakeholders. So if our basis is process and settings, we classify the feedback as formal and informal. So what we mean by formal feedback and informal? If in the class, let me take an example in the class. If in the class, I have asked a question to the student, if the student answers it uprightly, instead of just telling right, if I tell him you are in the right direction, you can further read on this. So here, basically, I am reinforcing the concept that the student is right and further where he can improvise himself. So this is an informal feedback. When I say formal feedback, it is more organized, it is more structured and devised and is rendered at a time in a proper setting. Second classification is purpose-based. It could be constructive, inspiring, and corrective. These are little overlapping. If I say you're doing very well, keep doing what the performance you are showing right now, it is an inspiring feedback. If I say that this is the way in this session you didn't do it much well, you can probably improvise yourself, I'm talking a corrective feedback. When I say how you can improvise and how better you can make it, I'm providing a constructive remarks here. So this becomes constructive feedback. The third important typification is based on the breadth of the feedback. Now, this is again one of the most important parts of our CBME, which emphasizes both on formative assessment as well as formative feedback. So formative feedback gives ample scope for the student or any stakeholder to improvise before it gets fixated onto something. Rather than summative is also important, but definitely formative feedback plays a very pivotal role. And fourth is the delivery mode. There are different models of feedback delivery proposed by different authors. There are quite a few. I mean, I could have listed all of them, but just for the sake of mentioning, we have Pendleton's model, Aloba, Setko, advanced inquiry model, sandwich technique. However, somehow, maybe that based on the comfort or use, we are more acquainted and more familiar and more usable is our sandwich technique. And this is also the most criticized technique of feedback delivery. The reason, or what the sandwich basically talks here, is that you have to sandwich your constructive feedback in between the positive feedbacks or inspiring feedbacks, which are the buns. So what happens sometimes is we overdo the floral praising or the floral inspiring so much that sometimes the meaty part, the constructive feedback, becomes very thinned out. So the basic concept, the reason or the purpose of the feedback gets diluted. So it was criticized a lot. But however, if practiced perfectly, it is one of the still best delivery methods for a stakeholder regarding the feedback. Subsequently, they came out with a better technique and they called it as a sandwich method, but ask, tell, ask. Where we ask the stakeholder what went wrong or what was it, how do they themselves judge it, and then tell our opinion about what went well, what didn't go well, how they can improvise, and end it with again asking them what they would like to do about it. Now they have heard both the things. So this was the feedback sandwich, basically ask, tell, ask. They got this one from Pendleton's model, which says, first ask the student, how was his performance? Then you tell, how was his performance? Again, ask the student, what were the scopes for his improvement? And then again, you add on what are the scopes for his improvement. So it is kind of an adapted version, but either ways, both the models are best. However, anybody feels happy with other modes also, they can still go ahead with it. So now we have told that is very important in CBME. We have told that it is a piece of information which will help us reiterate our particular behavior or improvise it. We also know how we can deliver it. So why do we need the feedback in the first place? First and the foremost, we need to clarify the good performance. How would I know that I'm performing very well if nobody tells me? Or how would I know that my performance, which I assume is right, but actually is not on the proper platform? So either ways, I need to have a feedback from a proper stakeholder to let me know about it. There is no point in asking my maid how I'm delivering a speech right now, but my stakeholders right now, my audience, my panelists, my organizers, they will play a very important role in providing the feedback. It will help develop the self-assessment. Just let us go back to our first slide where we had that rhino picture. If we had told the rhino that it is the horn of his own horn that is obscuring his landscape, wouldn't it push that person into self-reflection? Like, okay, what did I do wrong? Where can I do better? How did this happen? So it brings out a better quality information. It encourages dialogue and motivates our belief and definitely boosts our self-esteem. So when we start this feedback practice, so obviously that gap that exists between a student, a teacher, a parent, a teacher, or any of the stakeholder, that that gets becoming more and more leaner, and it motivates us to obviously do something better. Okay, this time my talk was like this, let me make it much better next time. This my performance was so and so, let me enhance it further. So it is definitely a very good tool. As I already said, it will provide different opportunities for us to close the gap by bridging it, just by taking feedback and acting on the feedback. And most importantly, it provides information to the teacher to improve his teaching, or if it is already perfect, to continue doing this, delivering the same teaching. Tell the students to improve their performance. There is always a scope for improvement, right? And institutions to improve their implementation regarding resources or the matters or the skill, whatever be the need that can be improvised. Okay, we have quite now been using the word stakeholders, right? So who are these stakeholders? Stakeholder is a person or a group or an organization or a system who affects or can be even affected by the organization. So stakeholders is not a terminology that is meant only for medical education. It is used wild in business, in customer care. Wherever you go, there is always a stakeholder involved. So in medical education, who are the important stakeholders? So before this session, I just let out a poll to generate a word cloud from among my fraternity members, colleagues from medical education. So I got this particular thing. So you can see that maximum number of colleagues, or my stakeholders, I should say, said students are the major stakeholders in the medical education, followed by teachers, patients. Okay, so apart from that, there's many also answered like policymakers, clinicians. Yes, clinicians, I believe, I mean, yes, there are clinicians who are teachers, but there are certain general practitioners who are not into teaching. So even they become an important stakeholders to you. Yes, rightly pointed. And then institutions, we have government, many other things. Somehow I don't see parents, even parents are important stakeholders. So are they right in giving me this word cloud of who are the stakeholders? Yes, they are absolutely right. So who are the types of the stakeholders? Basically, stakeholders can be internal stakeholders or external stakeholders. Though we divide it for the sake of their direct or indirect involvement, both internal and external stakeholders are equally important when it comes to feedback. So who are these external stakeholders? The suppliers to the hospital, the community workers or the community at large, the government, the NGOs, the policymakers, they all are our external stakeholders. Who are the internal then? The primary, who are going to be immediately getting affected by this new implementation. Those will be our primary stakeholders. They will get the maximum impact. They are none other than our students, the teachers, the patients as well. Ultimately, our intention is to make an IMG relevant as well as competent. So patients also happen to be our primary stakeholders. So secondary, the parents, the institutions, again, the policymakers also can come here as secondary stakeholders. So now we will more importantly concentrate on taking feedback from these stakeholders, okay? And we will see how can we collect information or data about the feedback. So how do we conduct the feedback for these stakeholders? So we have different tools for collecting the feedback: questionnaire, surveys, focus group discussion, multi-source feedbacks, in-depth interview, key informant, face-to-face interview. These all are, and the list is exhaustive. Now, just as the proverb says, not one size of shoe fits all, not one particular type of tool might be applicable to all the institutions across the country. It depends on so many factors. When you choose your tool, you have to be very careful. If I am having a medical college running in some rural area, probably having an in-depth interview with the parent or the student or the policymakers or the community would be a better way of collecting the feedback than sending out an online questionnaire. But but that does not mean I shouldn't be doing that. So it could be mixture of two. I can send out an online questionnaire or a paper-bound questionnaire as well as conduct a focus group discussion. Say during the parent teacher meeting, I would invite some of the parents to be to participate in the focus group discussion, right? So likewise, it cannot be one single tool. It can be mixture of different tools of feedback, as well as collect the data. Okay, now that we have known what are the tools, and I'm fine, now I have fixated that I would like to take a questionnaire based feedback from my student. Oh, sorry, excuse me. So how do I give an effective feedback and receive an effective feedback? So let us now talk about the do's and don'ts of the giving feedback. First and foremost, give a feedback which is labeled frequent, appropriate. Now, what does that mean? I cannot randomly go to any parent and ask, give me the feedback. The parent should be told that on this and this day, we would like to have your feedback. Similarly, tell the students that I would like to give you a feedback about your recent performance or receive a feedback on my performance. And it should be in appropriate setting and relevant to it. I want to take a feedback on how well my SDL implementation was for this year. Then there is no point in asking how was the teaching of my some XYZ class if it is not relevant to the STL training. So it should be appropriate, relevant, and frequent. Now, this is a place where most of us will fumble. Frequent. What is too much and what is too less? How frequent we should be. If it is an external stakeholder, you can probably have it yearly. But if it is an internal and important stakeholder, the primary stakeholder, I mean, it can be done at a frequent intervals. So does that mean, should I start taking every day the feedback from the students and give them every day? So what can happen? Dilution of it. The students will no longer take it seriously. Neither you will start taking their feedback. It becomes more of mechanical. So minimum gap between two feedback should be such that you have given the person scope of improvement, or you have bought yourself time to show that particular scope of improvement. Okay, so that will decide your frequency. Timely, constructive, actionable. So what do you mean by timely? I want to give feedback to my students at the end of, after the first sessionals, but somehow I couldn't do it. And already we are into second sessionals. So should I call my students a day before the second session and tell them that I would like to give you feedback on your first internals? That would be of absolute no use, right? It should be immediate, because that will give the student a real scope to improvise himself so that he does not repeat the same mistakes that he has been doing in the first sessionals. Okay, so that way he can improvise it in his second. Make it constructive. Do not tell them you didn't do well. Tell him how he could be better, what went well, what didn't go well. So that would make it more constructive. When I say actionable, here we are talking a strategy based. Now, what I mean by strategy based, if I tell, okay, you didn't draw a proper diagram, ideally shouldn't be. So your diagrams could have been more better. Now, rather than just saying your diagrams could be more better, if I tell him, why don't you go and see a PubMed journal or so-and-so book from so-and-so author, that diagram would be better when you incorporate. So now I'm telling him a strategy here. It becomes your actionable feedback. Your feedback should be behavior specific, right? So in the picture, you can see a man is yelling on his dog and saying, you're a bad dog. But what is the dog reciprocating? Could you be more specific, right? You cannot just tell me I'm a bad dog for nothing. You have to tell me where exactly I'm bad. Similarly, we have to give a specific feedback. Your performance was bad would be a vague feedback which will hold no meaning at all. Your performance in the seminar, your performance in the practical, your performance in the theory, or your performance in so and so could have been better. So make it more behavior specific. Keep it balanced and interactive. Listen also to them. Let them also talk. You also tell. Try to follow ask, tell, ask method. Keep it balanced. Now, what does it mean as balance? Suppose I conduct a feedback session right now for the session that we are running, and everybody says it's good, 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 and every good thing, and suddenly only one point where they wanted to emphasize it could have been better if there was more of animation. That one negative or constructive, if I would like to say, is said only once, then it gets diluted and it sometimes is missed out. And if we keep on telling all the negative parts of it and one positive, that positive behavior is not reinforced. So it should be balanced, whether you give it to the institute, whether you give the feedback to the student, to a teacher, to the from the parent, it should be balanced between positives and negatives. And the most important point that we are now emphasizing these days is these three pillars. What are those? The feedback, the feed up, the feedback, and the feed forward. Feed up is tell about what is happening, give the information, what goal they are looking out for. Then talk about the feedback, what went well, what didn't go well, how they can improve. Then feed forward is nothing but a strategy. So it is always better to even ask when you're asking for a feedback under these headings, to feed up, feedback, as well as feed forward. So what next now? Now that we have known how to give a feedback, we know from where we have to collect the feedback data, we know the tools, we know the types, we know who are our stakeholders from whom we are collecting. What becomes most important next is this. What is this picture? Mirror, mirror on the wall, who is the fairest of all? So I hope you can identify with this particular fairy tale. She's the evil queen from Snow White, who was in the habit of taking feedback from the mirror very frequently. And how was she? Right now, she is very, very angry because finally the feedback said that she was not the fairest of all, right? So this is how we all tend to, it is a human nature, we all tend to respond. So receiving of the feedback is also equally important. How do we know the feedback given to us or given to someone is going to bring out an effective learning, effective change in the performance? Is totally dependent on three things: how well they receive it, how well they understand it, and how well they act it. If there is a feedback received from a stakeholder to the institution, the institution cannot just deny that, no, we are implementing it very well. Rather, they should see, okay, if the parent feels that this particular implementation is not appropriate, why is it not? Do a root cause analysis and see, is it because the shortage of faculty that we are having? Is it because the faculty is not trained? That will bring in a change of performance. It will bring up more faculty development programs, probably train everyone and inculcate it. So do not be in a denial, be you are on the receiving end or in the giving end. So when you are giving, do tell your students or your stakeholders that how they should receive this feedback in a positive way to have an effective feedback. Remember, feedback outcomes, whether there is change in performance, is little difficult to measure, but the satisfaction to the feedback can be immediately measured. So we should follow all the do's and don'ts. And at last, we need to analyze it. How do we analyze? The feedback can be a quantitative feedback or a qualitative with open-ended questions. We have to do a very rigorous thematic coding, thematic analysis of all the narratives, and then act upon it immediately to serve the purpose of the feedback. Otherwise, the feedback will just be another paper dump for a waste garbage. So it will not serve its purpose. So with these, I would like to thank the organizers and audience and would be ready to take any queries. If I'm capable to answer, I'll do my best.
Thank you, ma'am. Thank you for the nice talk. You clearly explained the need for getting feedback in different formats in the curriculum and also in the subjects, and also from different stakeholders who all have should be approached. And a very valuable point is no feedback should stop at just obtaining it. That should be converted into action taken after getting the feedback. So that was a very valid point which we are taking. And we have a couple of questions or even more. How to remove bias in feedback?
Okay, could it be a little more specific from which stakeholder are we talking about? Are receiving end or the giving end?
It's a message from one of the participants.
Okay, let us answer in both the ways. Okay, bias in the feedback. One thing what we can do is, and which I usually follow is, Some people prefer that feedback be made optional, that people can write their information or they can exempt it. But when you give this optionality that they can mention their name or anything, there is always a bias comes in. Because if a parent is giving a feedback about the institution or the teacher, then he would always think that if I give a better feedback to this teacher, my son might get better marks. Or if the student is giving out his name, he would assume, though it may not be the fact, but it can happen that they will assume that the teachers can do. So you keep it universal. Do not make it an anonymous feedback in the first place. Second thing, do not have any personal. There is a way of constructing, designing a questionnaire for feedback. So we have to follow all those etiquettes of question. There should not be a personal, queries on that, and it should not be hurting anybody's sentiments. So neither the givers nor the receivers. Then the bias can be taken care of.
What is the difference between survey and questionnaire?
Yes, very well said. Now, questionnaire and survey both are present, is one of the most important tools of feedback, I must say. And when it comes to medical education per se, survey you might have seen mostly from if you buy a TV, you will quickly get a survey over there asking how is the quality, are you satisfied with this? There is a little scope for, that is mostly of quantitative first place. There is a little scope of you giving a more of suggestive part, okay, little scope. But in a questionnaire, when we include this open-ended questionnaire, and we should include in our feedback as well, it gives a lot of scope. It becomes more qualitative and quantitative type of estimation. Point two. Secondly, surveys in medical education, there is, as of now, there is no design present to how to design a proper survey, to be very frank. So the reliability and valuability of checking such surveys is a little difficult. But questionnaires, we have a very well-fledged how to check the validity, reliability. We have Cronbach's alpha, we have content, face, and all those, how to do about in questionnaire. But there is no designing framework meant for survey. Survey still can be used if you want only the quantitative data.
Can you please repeat feed up, feedback, and feed forward process with an example?
Okay, so let us say this particular session that we are going on. So I will ask you, how was my talk? We would like now a constructive, and I'll now give a feedback to myself. Yes, the session was good. Now I'm giving a positive feedback. Now I have to give a constructive feedback, right? So I will say it went a little fast. Maybe you could have been slowed down at certain places, and you can do it this one. And somewhere you say you could have spoken a little bit more on analytical part. Okay, I'm just bringing out my own points. So feed forward would be probably, assuming that the student does not know, you tell, for analysis you can go to this particular thing or this particular person or this particular video which talks about analysis, or this particular institution which is regularly doing this particular thing. So you are giving a feed forward. You are, and before the event person asks, okay, where should I go and seek this information, you are giving him a feed forward here.
What is the link between feedback and reflections?
Definitely there is a very strong reflection, and during the points when I was telling why is it important, when you give a feedback, it gives me time to self reflect or self assess my own performance. If probably I might have judged that I'm doing very well, but when the feedback says otherwise, I can stop at some point and think, reflect back where I went wrong and how I can improvise on myself.
Thank you, ma'am. Thanks for taking your time and answering every question. We would
Thank you,
like
sir.
to share your certificate online.
Sure, sir.
If you can stop sharing, I can do
Okay,
this.
sir.
As a token of appreciation, we would like to have this particular certificate. Thank
Thank
you.
you,
Thanks
sir.
a lot.
I would like to thank Dr. Logra, sir, and his team, and SRM and its management, and all the dignitaries for this wonderful opportunity. It's absolutely my pleasure. Thank you, sir.
Thank you. With this, we have come to 2 day long presentations of different scientific people directly from MCI, people who work, who developed the curriculums, people from various nodal centers, medical education units, who have excellently presented their topics, their areas of interest in a way where we can adopt it and follow for our future use. So this is the era where we need to change ourselves. So we should thank each and every speaker for this. With the end of scientific section, we will proceed to the validatory function. So I will hand over the session to Dr. Logra, sir, our organizing secretary.
So first, I like to thank all the participants. Nearly more than 400 registration has come, and all the success goes to the participants. They have participated, and nearly more than nearly 105 abstract has come for this national conference on implementation of competency-based medical education. And we have divided them into poster and oral presentation. Of course, short film competition also there. And I request our beloved Dean to announce the prizes, the first prize, second prize, and third prize for oral presentation, and then poster presentation, and also this short film. We have one prize for short film competition. So I call upon our beloved Dean to announce the results.
Thank you, Dr. Lograj.
Yes, sir.
At the outset, I thank the entire team for organizing a wonderful program. And I have to thank all the participants as well as the resource persons who have conducted very exorbitantly done CME, and it is very educative. And hopefully the participants learned a lot. And I have to congratulate the team, CME organizing team at the medical education unit under the leadership of Dr. Lograj. And now I am very happy to announce the what is this?
Oral presentation.
Announce the presentations for winners, oral presentation winners. First prize, Dr. Savita D, St. John's Medical College, Bangalore. Dr. Savita D, St. John's Medical College, Bangalore.
Yes, sir. Yes, sir. Next, this is a certificate. This is a certificate for her, sir.
Yeah, Dr. Savita can have the certificate. Thank you. Congratulations. And oral presentation winners, second prize, Dr. Syed Irfan Ali, Great Eastern Medical College, Andhra Pradesh. Congratulations, Syed Irfan. Next one. That is a certificate for you, Syed Irfan Ali. Congratulations. Go to the next one. Oral presentation winners, third prize, Dr. Pooja Juneja, BPS Medical College for Women, Haryana. That is your certificate. Congratulations, Pooja Juneja. Poster presentation winners, first prize, Dr. Rati Tandon, JNU Institute of Medical Science and Research, Jaipur. That is your certificate, Rati Tandon. Congratulations. Second prize, Dr. Preeti Shenoy, Manipal Academy of Higher Education, Manipal. Congratulations, Preeti. This is your certificate. Poster presentation winners, third prize, Dr. Navita, Andhra Medical College and AP, and Dr. Aparna, SRM Medical College, Katangalathu. Both of them sharing this third prize. These are Dr. Navita. This is your certificate. Congratulations. Dr. Himaja Reddy. Short film winners, Dr. Himaja Reddy, SP Medical College, Tirupati. That is your certificate, Himaja Reddy. Thank you. Congratulations.
So thank you, sir. Thank you for announcing the results of the national conference, both the oral and poster presentation and short film competition of this online conference. Sir. Thank you, sir. Thank you.
Thank you.
I call Dr. Balaji to give vote of thanks.
Oh, yeah, before saying the vote of thanks, because a lot of queries are coming about the feedback form and all, we'll be sharing the feedback form and the certificate will be distributed accordingly. The certificates for all the oral and poster presentation others also are noted by the concerned persons and it will be shared to your thing. So don't
I
worry
think
about that.
prize win one announcement. The prize winners, please send your account numbers to the email ID, official email ID. The money will be transferred to your account. The prize winners.
Yes, as already said, cash awards are being mentioned for the different prices and that will be. So coming towards the end, giving the vote of thanks. So it was I had immense pleasure in hosting this conference along with our organizing secretary Dr. Logra sir, having good experience speaking with the speakers and the participants. I want to thank everyone for being so energetic and actively participating, posting different questions and involving a lot in the presentations as posters and orals. I want to thank our organizing team, and before that, I want to thank the patrons who have allowed us to organize such a. I want to thank all the patrons who have allowed us to organize such a conference, and I want to thank our Dean Sir, Provost Chancellor Medical Sir, who has helped us, who have been always support backbone for us in helping us. Whenever we want any support, we approach them either for having the ITKM support or the webinar links. They were completely in support. In fact, even for the speakers, when we feel that one particular area we need an expert, they were immediately suggesting us. So I thank our Provis sir and also Honorable Dean sir for hosting, and thank you for joining the session also, sir. I thank my organizing team who were helping us then and there. I thank the ITKM support without whom we could it could not have happened. And I thank all the speakers who have taken their time from their busy schedule coming forward with all the whom we are getting the feedback in the chat box. And it's very nice to see all the messages we're getting in the chat box. Thanks for all the speakers. I would like to thank the audiovisual department. I would like to thank the maintenance department, the housekeeping department who are being staying behind but helping us in making these conference a lot successful. And I thank my postgraduates and other people who have supported it. I would have missed someone for the want of time. Just it includes everyone, even if I have not mentioned them. I once again say thanks to everyone who have made this conference a real success. Thank you. So we'll close this session.
The feedback already list. You can, if you send the feedback, you can automatically get the certificates.
The feedback form has been released.
Yes. For poster, those who have presented poster presentation, you will get poster certificate. Those who have presented oral certificate. And for all participants, the participation certificate. Just answer your feedback form, automatically you will receive the certificate. All, it has been sent to your mail. All of you go to your mail and then answer.
So just check your mail and everything will be there. In case if any issue, you can approach us. We'll send a link to you for you to reply.